subjects in that, and that also they showed that there is statistically increased chances of Parkinson's disease in patients who have Sjogren's syndrome as compared to without Sjogren's syndrome. A second case, a 74-year-old male presents with instability, imbalance, and multiple fall since 2 years. Bradykinesia, cortical rigidity, there is no history of tremors, memory disturbance, bladder bowel disturbance, speech difficulty. You started on syndopa since 2 months, no improvement, MRI shows small vessel systemic diseases. Clinical diagnosis. So again, one disclaimer, these clinical diagnoses are not made by me. It is what the clinical diagnosis the neurologist has written and sent to us. So if any discrepancy is there, you can clarify with the neurologist. He's sitting there. Any clues? Vascular Parkinson's, okay. Anyways, it came with a diagnosis of query early Parkinson's disease. Okay, since it was a diagnosis of Parkinson's disease, the patient was sent for F-DOPA scan, not FDG scan. And this is the F-DOPA scan. No abnormality, it's totally normal. So in this case, we could rule out that it is not idiopathic Parkinson's disease. We had asked for an FDG scan. Unfortunately, the patient didn't turn up for FDG scan. But in this case, we ruled out that it is not a Parkinson's disease. You have to see for some other cause. Might be drug-induced, might be essential tremors, whatever it is there, but it is not idiopathic Parkinson's disease. No, in same sitting it cannot be done because, as I told now, both the rays which are emitted are both 511 kilo electron volt. So the computer will not be able to differentiate which one is what. But since the half-life is only 2 hours of fluorine 18, so we can do today and tomorrow. Today you can do FDG, tomorrow you can do F-DOPA. That is not a problem. But we cannot do it on a same sitting. Last case, a 60-year-old male, symptomatic since 4 years, speech and sleep disturbances, urinary urgency, vertical gaze restriction, there is history of repeated falls, which was mildly reduced on taking medication. Clinical diagnosis, anti-glon, very good. This is movement disorder talk. Okay, then PSP, MSA overlap, very good. People from this side, any thoughts? Okay, it came with a clinical diagnosis of PSP. Since it was PSP, FDG was ordered. We did an FDG scan. These are the scans. Anything which you can interpret? Very good. There is an asymmetry. You can see that there is some uptake reduced here in this region as compared to this side. So there is an asymmetry in FDG pattern. And there is preserved or mildly increased hypometabolism in the brainstem. So as I told you, brainstem is not hypometabolic, it is not PSP. So asymmetry goes with CBD. So we gave, it might be CBD, but the patient has come with PSP diagnosis. So how to put CBD? Then we search the literature. There are cases, in fact, this is one in which the autopsy was done for some other reason. The patient has presented with PSP, but the patient has pathologically confirmed corticobasal degeneration. So then we confidently said that it is corticobasal degeneration. So what are the take-home messages in this? very simple take-home messages. If you are thinking of idiopathic Parkinson disease, please send it for a F-DOPA scan or a TRODAT scan. Please don't send it for FDG scan. FDG scan will be useless. Second thing is, again, if you are thinking of Parkinson plus syndrome, atypical Parkinson's, then FDG scan is indicated. Okay, plus minus TRODAT scan, but FDG scan is indicated. Wherever the scan is being done, ask them to do a dedicated brain study. If not 10 minutes, if they have crunch of time, at least 5 minutes should be done. 1 minute scan, that too when it's covered in whole body, I will say, not at all, it's punishable by crime. Punishable, I'll say. You should not do it. And detailed history is always important before interpreting. I don't do. In case of any doubt, then we should always call the neurologist and talk to them. Now let's see how much your what is seen in this imagination. Very good, DLBD. Anything else anywhere? I see a heart. It's not always about study. Thank you. Yeah.
Different mutations that can also show DOPA scan positive. So in that case, because you saw the 3 clinical scenarios, they have the different symptoms are there which is not for the idiopathic. So in that cases, we'll love to do the genetic test and all those things. That could be the idiopathic. We cannot say the idiopathic, but many of the genetic Parkinson's we see the positive. What you're saying as idiopathic.
Understood.
So that things to be, I'm to be saying, we should consider that also.
Whenever we are presenting, usually we'll present the typical cases. We'll not present the atypical cases. But again, genetic, if you're talking about, usually the history is what is more important. As I told, without history, we don't interpret a FDG scan. So that history will be younger onset, maybe the family history. All those things is what comes into play in that case. Then it is very difficult.
It's a definite entity, right? YOPD, that's what we call. So YOPD scans may not be classical. What he has shown and what we generally encounter, the rostrocaudal gradient, posterior putamen more than anterior putamen and caudate, that is usually seen in classic idiopathic Parkinson's disease, which is like a degenerative pathology. But in YOPD, there may be extensive dopaminergic loss, leading to almost no uptake of DOPA or TRODAT in the brain. So usually YOPD scans are difficult to interpret, and just on the basis of TRODAT or DOPA, you cannot label them as YOPD. We have to have an FDG scan, and we have to have a proper conversation with the neurologist.
So I finished my first talk in maybe 20 minutes. Yeah, please.
Sir, I am Dr. Jayashree, here consultant neurologist with special interest in movement disorders. So my doubt is how much we can rely on this FDOPA or TRODAT for the for follow-up or for prognosis, because so like the case you have mentioned, Sjogren syndrome with clinical suspicion of PD plus, but turned out to be IPD. Whether during follow-up the patient behaved as IPD or PD plus.
Actually, 2 years follow-up is there. I have not got any feedback that the patient is something else.
Okay. So because when I'm asking for FDOPA for PD plus, though we are getting as IPD, like there's a clear asymmetry and rostrocaudal gradient, but they are behaving like what the clinical suspicion is, like they're behaving like PD plus and not
No, in
PD.
that case, I will say that you do an FDG scan also. There might be
Okay.
some overlap syndrome or something which we
Overlap.
don't know, but we have to do both the scans in that case. If there is any red flag which is there, then we have to do both the scans.
Yes. Thank you.
If a patient, first of all, a very good talk. Thank you very much.
Thank you,
It was very clear. Do you insist that the patient should be off Syndopa if he's taking? Because many times these patients are put on Syndopa, whatever disease they have. So do you insist that they should be off the drugs, or you can do the scan in spite of whatever they are on?
Literature says that we should take off the, but
For how many days?
not 3-4 days. But I have not seen any change, sir.
So
Normally,
they
what
may
we do
continue.
is all the scans are done on Syndopa only.
Okay,
We
so
don't stop.
it won't change the.
No, it won't change. One thing also, that Trodat scan, actually, like maybe madam from Gangaram Hospital, madam is doing a lot, but there is a lot of logistic issues in doing a Trodat scan. Patient discomfort, staff discomfort. It takes almost 1.5 hours to make a Trodat, like label that Trodat with technetium. And after injecting also, the patient has to wait for 4 hours. Then only we can do the scan. No, sir. I don't think. That's the reason we have almost shifted from Trodat to Avdopa. We don't do Trodat routinely. We have done for almost all cases, we do Avdopa scan. Scanning itself will take 1 hour. So the patient, once he comes, he will be staying in the department for 6 to 7 hours. So it's a torture for the patient also. Amyloid imaging actually is not available in in India itself, I'll say.
Yeah.
That's the reason if I give a talk on amyloid, it will be more of a theoretical talk.
Yes, sir. In
No
future,
experience.
because now with maps coming, I know they are not so efficacious, but in future they may be. Therefore, it becomes imperative that we start diagnosing them.
Previously amyloid was made by Pyramil,
Okay.
but they have sold it to some European company.
Oh.
So one of those European companies, actually NIMS was to collaborate with one of the Australian companies. They were developing some Alzheimer's disease drug. So NIMS was supposed to be a center. So that European fellow, he contacted us, what should be the price they should keep for
Amyloid.
amyloid image. We told FDG is done for 15,000, 20,000. I don't know how many dollars, some $200 or something.
Yeah.
There they do a PET scan for $1,000. So he was very disappointed. But then it never materialized. Okay. Okay, my second talk, actually it was Dr. Pushpalta's madam talk, but I will be doing on autoimmune encephalitis. It's again a very big topic and challenge. First, I'll show what are there are multiple, and every day almost some of the new antibodies are being discovered for this. Few of which I have put here. These are the antibodies against intracellular antigens who MMR2, GAD, all of these produce limbic encephalitis, and the cancers which they are associated, small cell lung cancer, HUMA2 is testicular seminoma, GAD is thymoma or small cell carcinomas. Similarly, these are intracellular. Then we have which are against synaptic receptors like NMDA receptors. Again, madam has shown ovarian teratoma case. AMPA receptors, limbic encephalitis, thymoma, small cell lung carcinomas, then GABA receptors, small cell lung carcinoma, limbic encephalitis, GABA B, GABA A receptor, then dopamine receptors, dopamine 2 is basal ganglia encephalitis, again thymoma, Hodgkin's lymphoma. Then there is another set which is against antibodies against ion channels or other cell surface produced LGI1, limbic encephalitis, more association with thymoma, and then Casper2, again presenting as MOVE1 syndrome or limbic encephalitis, thymoma, DPPX, MOG, aquaporin 4, GQ1B. These all are the antibodies. With so many antibodies and multiple more antibodies which are being discovered, still the total number of autoimmune encephalitis cases, it's only 30 to 40% which are antibody positive. Rest everybody is probable or what is called as antibody negative, seronegative autoimmune encephalitis. Now there are certain diagnostic criteria which has been taken from this Lancet Neurology. This is the latest which is there in 2016. So they have classified like possible autoimmune encephalitis. Subacute onset, rapid progression of less than 3 months. 3 months is very important period. You'll see in all the criteria 3 months is there. With short-term memory loss, altered mental status, psychiatric symptoms, then at least one of these, CNS, seizures not explained, CSF pleuritis, MRI features as to encephalitis. Then we have, this is possible autoimmune encephalitis. Then we have a definite autoimmune encephalitis. Again, of symptoms, which can be working memory deficit, seizures, psychiatric symptoms. Then bilateral brain abnormality on MRI. At least one, either CSF pleuritis or EEG with epileptic or slow wave activity. Then there is acute disseminated encephalomyelitis. Multifocal clinical CNS event of presumed inflammatory demyelinating cause, encephalopathy that cannot be explained by fever, abnormal brain MR, multiple are there. Then no new clinical MR findings after 3 months of symptom onset, and reasonable exclusion of alternative causes. Okay. Then we have anti-NMDA autoimmune encephalitis. Same thing, rapid onset, less than 3 months. 4 of the 6 of measures, abnormal psychiatric behavior or cognitive dysfunction, speech dysfunction, movement disorders, decreased level of consciousness, autonomic dysfunction or central hyperventilation. One of the following, abnormal EEG, CSF. Diagnosis can also be in presence of 3 of the above groups, whatever it is there. Okay. Then we have a specific called Bickerstaff's brainstem encephalitis. In this, there is rapid progression of less than 4 weeks, decreased level of consciousness, external ophthalmoplegia, ataxia. Usually there is present a positive IgG, anti-GQ1B antibodies which are present. Then Hashimoto's encephalopathy. Encephalopathy with seizures, myoclonus, hallucination, or stroke-like episodes, subclinical or mild overt thyroid disorders, brain MRI normal or with non-specific abnormalities, presence of serum thyroid antibodies, absence of neuronal antibodies in serum and CSF. Then antibody negative probable autoimmune encephalitis. Progressive rapid progression less than 3 months of memory deficit, altered mental status, psychiatric symptoms, well-defined syndromes of exclusion of well-defined syndromes of autoimmune encephalitis, then either MRI abnormality, CSF pleuritis, or the brain biopsy showing inflammation. So why I have shown, there are like, this is the seven diagnostic criteria I have shown, and none of them has got FDG in it. So why it is so? And day in, day out, we are using FDG for diagnosis of autoimmune encephalitis. This is the literature search which I did when I was going through all those, and none of them showed any FDG. So from 1981 to 2025, there is 21,921 results of MRI in autoimmune encephalitis, of which almost 1,000 are only in 2024. What about PET-CT? When it comes to PET imaging, there is only 780 results. Out of those, that is 21,000, more than 21,000, PET is only in 780. And that too, in past 10 years, Most of them is in 10 years, I'll say that thing. More than 500 out of those 780 is in 10 years. And in 2024, only 40 papers have been published. So there are a few nuclear medicine residents also. I'll say if you want to, it's like publish or perish now. If you want your modality to be in the diagnostic criteria, then we have to publish more. Other reason being, in whole of Andhra and Telangana, if I want to find out how many nuclear medicine physicians there will be hardly 25 or 30 nuclear medicine physicians in whole of Andhra and Telangana. Vijay Diagnostics have got more neurologists than, radiologists than whole of Andhra and Telangana nuclear medicine physicians. So that number also matters a lot. Anyways, coming to what are the PET findings which we normally see in autoimmune encephalitis. Everything can be seen. It can be a hypometabolism, it can be a hypermetabolism, it can be a mixed pattern of both hypo and hypermetabolism. That's the reason history is a must before we any interpretation of any FDG PET CT. However, still there are few clinical patterns which are normally seen in the encephalitis, which gives us a clue that what it might be. First of all is anti-LGI1 antibodies. When you see this, like there are certain focus which are very bright and rest of the other brains are down. It looks like an ictal pattern. So what happens is anti-LGI1 most of the times will have electrographic seizures. If you do an EEG, you will see the seizures, but the patient will not manifest seizures. So when they come for PET CT, we don't know they are having seizures or not. So we'll inject, we'll get something like this. So you can see mesial temporal involvement is there, the insular involvement is there, focal involvement is there. When we see this picture, we almost say that it might be an anti-LGI1. Of course, the history should not be of epilepsy, it should be of seizures. Less than 3 months of history should be there. Another case, you can see that there is significant hypermetabolism, and then there is cross-cerebral diastasis also on the other side, like left frontal and right cerebellum. So again, this is what we see in anti-LGI1 antibody syndrome. Second is like AMPA antibodies, NMD antibodies. AMPA, as I showed, it's a type of limbic encephalitis. So whenever we talk of limbic encephalitis, it's the mesial temporal cortex which will show increased metabolism. Apart from that, it can have other areas of increased metabolism and hypometabolism, but usually characteristically the mesial temporal lobes will show increased activity. Then anti-NMD encephalitis, posterior hypometabolism. You can see the posterior hypometabolism. Apart from that, since anti-NMD have some psychiatric symptoms, they'll have some behavioral abnormalities. Usually we'll see hypermetabolism in the frontal, basifrontal cortex, which can explain that these behavioral symptoms in that. Hashimoto's encephalopathy. Again, Hashimoto's encephalopathy, you can see that increased uptake is there in the basal ganglia, sensory motor cortex, some increased uptake in the cerebellum. Usually cerebellum will have lesser uptake as compared to the cortex. Mesial temporal cortex will have lesser uptake as compared to lateral temporal cortex. So if you see any uptake which is equal to or more than the lateral temporal cortex, it's always abnormal. In this case, I can see that mesial temporal is showing more uptake as compared to the lateral temporal cortex. So this is normal. When in this case, we have done a PET CT also, whole body PET CT. Usually in our center, for any patient who comes with autoimmune encephalitis, we'll do a dedicated brain along with whole body. Okay, so in that case, we found that there was uptake in the thyroid gland, and subsequently the patient had anti-TP antibody positive. So this is case of Hashimoto's encephalopathy. Then Rasmussen's again, characteristically you will have atrophic changes, hemiatrophic changes will be there on MR. Same thing, it can be correlated in the PET. You will see those areas where there is reduced, the atrophic changes are there. You will see the reduced FDG uptake characteristically on one side of the cortex. Apart from all these things, the like in movement disorder, it is very difficult to follow up those cases, like with PET-CT or with F-DOPA, as somebody was asking. But in autoimmune encephalitis, we can do a pre-treatment and post-treatment scan. Like in this case, the pre-treatment scan, you can see that there is increased uptake in the mesial temporal cortex with reduced uptake other areas. After treatment, then after 6 months, after post-treatment, we can see that there is normalization of the and the area which was showing increased uptake has now become hypometabolic. But usually in autoimmune encephalitis, repeat PET is indicated only if there is some new onset of symptom, or if you want to taper down the medication. In that case only, we usually prefer this repeat PET. Now, as I told, there's a lot of talk about whether PET-CT is good or MR is good. So there's a lot of literature evidence in that also. This is the paper from Nimhans, in which they said that the MR was abnormal in 73.9% cases, while PET was abnormal in 93% of cases. And the sensitivity of FDG PET was 94 when compared to 94% when compared to MRI. This is another paper from French group, brain metabolic alteration in seropositive autoimmune encephalitis, in which they have shown that the brain PET was abnormal in 98% of cases, while it was in 53%. That was in 22, this was in 2023. And recently in 2024 from AIMS group, Manjari Tripathi group, they have published this role of FDG PET in definitive and presumed autoimmune encephalitis, in which they have shown that the overall sensitivity of FDG PET is 86%. MRI abnormality was detected in 22%, that is 22 cases, that is 42% of cases. More importantly, PET was positive in almost 76% of MRI negative cases. So I think it's high time that PET-CT should be included in the clinical criteria also. So now, seeing all these, whatever like the patterns are there, which normally we see, now we come to the case study. A 69-year-old male presented with memory disturbance since 1 year, urinary disturbance since 6 months, slowness of activity, navigational difficulties, right-handed tremors and rigidity, postural instability with backward fall, minimal improvement with syndopa, MRI brain shows diffuse atrophic changes in lacunar infarct. Clinical diagnosis. Anybody can answer. Again, a disclaimer, this is the clinical diagnosis with which the patient come to us. It's written in that sheet. We have not made the diagnosis. CBD PSP, very good. Vascular. Okay. So it was, clinical diagnosis was PSP. Query PSP, it has come to us. Since it was PSP, again, FDG was ordered. So this is the FDG scan. The age is 69 years. So a certain amount of atrophy, anyways, it was seen on MR also. So we can see that some atrophic changes are there, which is showing hypometabolism. Apart from that, any other abnormality? Okay, this uptake is there in the mesial temporal cortex. There is some uptake in the midbrain on the right side. The increased uptake in the basal ganglia. Then the sensory motor cortex also showing uptake, increased uptake. So this case was not looking like a PSP or any other thing. It looks more like an autoimmune encephalitis to us. So we asked, can we do a whole body scan for this case? Because only for brain it was sent. Then we asked whether we can go ahead and do a whole body scan. Our neurologists, they are very good. They said, okay, do it. So it was a surprise actually. This is the MIP image of the patient. Maximum intensity projection image of the patient. We can see there is a increased tracer activity in the lung. Along with that, this esophagitis is there. Few other increased activity seen in the vertebrae. So this was a surprise actually. When we went to the fused images, speculated mass in the left lung, which is showing increased uptake, increased FDG uptake. Along with the nodes, patient also had the skeletal mets. So actually what was being thought as PSP, we thought that it is autoimmune encephalitis. It finally turned out to be paraneoplastic. Pardon? I'll show you again. See, in this case, first of all, there is patchy increased uptake. I'll not say that symmetrical, patchy increased FDG uptake is there in the frontal, sensory motor cortex, in this, the temporal, then the basal ganglia, asymmetrical uptake in midbrain, mesial temporal cortex. So as I told, this is hyper plus hypometabolic path. Mixed is there, but mesial temporal is what clinches the diagnosis. Yet it is some limbic encephalitis. Okay, as I told, mesial should show less uptake as compared to the. So that's the reason we thought that it is encephalitis and it is not PSP. So this finally came out to be CA lung actually. The other case, 71-year-old male, history of involuntary tremulousness of all limbs since more than 5 years, unable to hold objects, occasional swaying to sides and gait disturbance since 2 years, behavioral abnormalities since 3 months, which included aggression, picking clothes, occasional urinary incontinence, speech abnormality in form of reduced clarity and output, mild memory disturbances, recently noticed by attendants. Investigations, CSF glucose chloride was normal, protein was mildly elevated. WBCs, there were 12 cells in 12 WBC in CSF, of which lymphocytic predominance was there. Other gene expert and everything was negative. Autoimmune pallor in both blood and CSF was negative. Anti-TPO antibodies, TG antibody was negative. MRI T1 hyperintensity in substantia nigra as to Parkinson's disease. Diffuse cerebral atrophy, Fazeca grade 1 ischemic changes, infarct in right frontal lobe, and chronic Lachner infarct. Again, clinical diagnosis. You want to go back? Okay. An MDA. I understand that I'm giving a talk on autoimmune encephalitis, but when this patient came, he didn't have a diagnosis of autoimmune encephalitis. So you can come out of autoimmune encephalitis and think about it. MRI says Parkinson's disease with, right frontal lobe infarct. Actually, there was a long list of differentials in the case sheet. First two are these, vascular PD or atypical PD. With this, the patient had come. So again, FDG was ordered. You can see increased uptake in the sensory motor cortex, some uptake in the prefrontal cortex. Then increased uptake you can see in the basal gang, in the putamen, but you cannot see the caudate. Increased uptake in the brain stem and mesial temporal cortex. Then there is the uptake in the vermis and the dentate nucleus. So again, this fits into autoimmune encephalitis or frank limbic encephalitis, but it is not explaining all the symptoms. Okay. What you see is that this, you can see huge areas. So the patient had, apart from autoimmune encephalitis, patient also had the dilated ventricles. The Evans index came out to be 0.36. So in this case, it was actually autoimmune encephalitis with normal pressure hydrocephalus. The last case, 68-year-old, pardon? See, and whenever there is a normal pressure hydrocephalus, you have to first withdraw the CSF and see whether there is improvement or not. That is what is the thing. Anyways, for that case, after 2 days, they did an MRI protocol also dedicated to CSF study, and it also proved as normal pressure hydrocephalus. The last case, 63-year-old female, present with recent onset bradykinesia, imbalance while walking, sleep disturbances, mild memory disturbances, urinary agency, visual hallucinations, and the patient has a history of C endometrium surgery, which was done 10 years back. 10 years back, the surgery of C endometrium, the first thing which came into the mind was whether it is related to C endometrium or not, metastasis. Okay. But our, before coming to us, the patient has already undergone a PET CT done, which was normal. So they ruled out that it is not metastatic. So then what can be the other causes? Iglon, okay. Anyways, this came with the history of query DLBD, query autoimmune encephalitis. This was referred from outside. Reshma, you don't think about it. She's thinking which case. Okay, so this was referred from outside. Actually, so query DLBD, query autoimmune encephalitis. Okay. Again, the same thing. They first thought it's C endometrium, and patient has already undergone a PET CT done 4 months back. It has come to a review to me. But again, the problem, same thing. They have done from vertex to thigh, 1 minute image of the brain, which is uninterpretable. So we asked them to repeat a brain scan in our dedicated brain study. We did only a dedicated brain study for this case. Okay. So this is the dedicated brain study finding. You can see multiple patchy areas of hypermetabolism. Sensory motor cortex, then in the insular region, basal ganglia is increased, mesial temporal is increased, increase in the brain stem. Everything fits into autoimmune encephalitis or basically limbic encephalitis. So when we told the neurologist that it looks like limbic encephalitis. Then she could correlate, okay, yes, 4 months back, the patient had undergone a PET CT, and that there was increased uptake in the thyroid gland. So then they did the autoimmune and that all anti-TG antibody and anti-TP antibodies, which were positive. So it was basically a case of Hashimoto's encephalopathy. So last slide, what is the take-home message? PET CT actually picks up very early metabolic changes in the brain in case of autoimmune encephalitis. It is highly sensitive, but I'll not say highly specific. Only if you see hypermetabolism in sensory motor cortex, hypermetabolism in insular cortex, hypermetabolism in basal ganglia, brain stem, dentate nucleus, mesial temporal cortex is what makes it very specific. Otherwise, it is sensitive but not specific. And we have the advantage of doing a whole body scan in which we can pick up the cause of what is causing the autoimmune encephalitis. And again, it is useful in treatment response if there is onset of new symptoms and dose reduction. Thank you. This, for those who don't understand Hindi, it says शाखों से टूट जाएं वो पत्ते नहीं है हम आंधी से कोई कह दो कि औकात में रहे. Means make yourself so strong that even the typhoon, hurricane, they are not able to hinder your progress. Thank you very much.
Thank you, sir, for making it interactive mainly. So,
Thank you very much. One of the things which you kept on saying is that ask for a dedicated brain PET. Now, but the logistics problems are that cost. So because whenever we do anything with the brain, we are also worried about that paraneoplastic part of it. So therefore, there's a temptation of doing the whole scan. So how should we approach it?
Sir, as far as we are concerned, we don't charge anything extra for dedicated brain. It is same in that. Same, maybe because we get a lot of neurology cases. Yes, you have to just mention there, the whole body scan plus dedicated brain study. No, we don't charge extra. Yeah, please, everybody is welcome to send to us.
we have a small announcement prior to the lunch. After this, we'll be breaking up for half an hour session for lunch, following which we'll start with the remaining of the lectures. Come back soon.
Yeah, with so much of discussion on movement disorders, we at KIMS, we have brought focused ultrasound for tremors. And this is a totally non-invasive procedure, daycare almost, that therefore even if anybody there with essential tremor, disabling essential tremor or tremor predominant Parkinson's disease, please take this as an opportunity to send patient for such a revolutionary treatment. Yeah. Now we go for a lunch break. Thank you.
keep you awake as much as possible, and we will see some interesting cases so that interaction keeps your sleep away. I have a little bit tweaked this topic as imaging approach to LETM. LETM is an entity which troubles us on our day-to-day practice. And for the residents, if you ask me what exactly is LETM, LETM stands for longitudinal extensive transverse myelitis. And as per the definition, lesion of spinal cord where 3 or more vertebral segments of the cord is involved. So anything in longitudinally, if 3 or more vertebral segments are involved, it is called LETM. Anything less than that is short myelitis. There is one more entity. When I was reading this, it is known as ultra LETM. That means it is defined as a lesion involving 10 or more spinal cord segments. So LETM is 3 or more vertebral heights in its longitudinal axis. As we all know, there are so many etiologies for LETM, starting from immune-mediated or inflammatory conditions, neoplastic, infectious. So very difficult to remember the etiology-wise what exactly causes LETM, including vascular and so many metabolic conditions. But what I wish to know before I read an MRI of LETM cases are, what is the age of the patient? Because we can narrow down so many differential diagnoses. We have a priority list for the age. Whether if the patient is a pediatric age group or a young adult, we have a differential diagnosis list of differential. How is the onset? Whether it is sudden onset, hyperacute onset, think of vascular, or is it acute or subacute, infective, then inflammatory, long-standing. There are chronic disorders which can have like spinal dural AV fistula, so many other etiologies. And any other clinical clues following your steroids patient improved. After the steroids, the patient has worsened. Those etiologies, treatment history also help us to narrow down the differential diagnosis. And previous neurological symptoms, was the patient having prior optic neuritis, prior myelitis, or something which is recurring. All this can narrow down our differential diagnosis. So please go into all these things before you jump to reading the MRI images. So these are the priority list in the which I have made. If the patient age group is a younger age group, what all we should think. In the middle age, what all we should think, and elderly. We will see the cases rather than reading them individually. So first case, this is a young lady, 1 month history of blurry vision and intermittent headaches. When she presented, she was not a known case of hypertension, but her presentation BP was very high. And to go with, fundoscopic examination showed bilateral blood, disc margins, cotton wool spots, macular edema, arterial attenuation, all those typical of hypertension, and hemorrhages and choroidal infarcts. And this was the imaging findings. What does it show? You can see that longitudinally extensive myelitis, more than 3 vertebral height. This is a FLAIR image. This is a T1 weighted image. This is a T2 weighted image. This is ADC. This is not true restricted diffusion. It's a facilitated T2 shine through. But see the extent of lesion. And after the treatment, follow-up MRI showed this complete resolution of the imaging findings. Absolutely no scar or volume loss. So what is your diagnosis? It's very simple, right? With this history, this presentation, and complete resolution of the imaging. It was a press with the spinal cord involvement. Okay, clinician should suspect press spinal cord involvement when patient have mild or no neurological signs accompanied with extremely elevated blood pressure and lesions in the spinal cord. The spinal lesions alone may be a subtype of press SCI. Gray and white matter transversely also it may be extensive. And press is very rare and usually involve young hypertensives, especially the male patients. With treatment, generally symptoms resolve completely. Even the imaging in a follow-up will show near complete resolution. So think about this isolated entity in this typical historical background. 57-year-old man with a small cell lung cancer presented with profound ataxia, proprioceptive sensory loss following initiation of checkpoint inhibitor immunotherapy. So this was the imaging finding. What is there here? In the sagittal images, T2 star images, you can see longitudinal extensive involvement of the cord, but in the axial sections, there is particular involvement of the predilection to particular tracks, the posterior columns in the V-shape involvement. And very subtle. I am not able to appreciate very clearly, but there was subtle enhancement in these tracts. With this history and this imaging findings, what do you think? Anyone? This was an isolated paraneoplastic myelopathy. Hallmark radiological features of paraneoplastic myelopathy includes longitudinal extensive symmetrical T2 hyperintense tractopathies that enhance in up to 50% of the cases. Especially they have involved either posterior column or combination with lateral column. Most of the time, anti-CRMP5 or anti-U or anti-ampifycin antibodies are often associated with that. You can see another case, similar case in this selective tractopathies. You can see that lateral column is enhancing. So insidious or subacute onset, disability progressing quickly and is generally severe, poor response to steroids. Imaging is positive only in 50% of the cases. Imaging findings includes LETM, enhancement of the tract specific abnormalities, particularly along the lateral or posterior column are very characteristic. When you see this lateral or posterior column with subacute onset worsening rapidly in elderly, think about paraneoplastic myelopathy, especially if it enhances. A 35-year-old man presented with 1 month progressive worsening of lower limb extremity weakness, paresthesia, difficulty with ambulation. On examination, he had a power of 3/5 in both lower limbs. CSF showed mild elevated protein with normal glucose in 20 cells, predominantly lymphocytes. Alleloclonal bands were negative. Anti-aquaporin and anti-MOG antibodies were not detected on the serum and CSF both. It's very easy, I think. LETM extending from C2 all up to the D2 vertebral body, and you can see that some leptomeningeal enhancement, especially the subpial nodular enhancement in the sagittal, and on the axial sections you can see this subpial enhancement, rind of enhancement. What is this? Very classical, right? Yeah, it's a spinal cord sarcoidosis, like a trident sign, a central canal enhancement associated with trident-like subpial thick rind of enhancement. Where else it can be seen? Any other diseases where it is reported? In the latest Green Journal of Neurology, there was a case similar to this. It turned out to be a lymphoma, dorsal subpial enhancement. So involvement of CNS is very rare. 25% of all sarcoid patients may involve, especially the spinal cord involvement is extremely rare. And there are several stages. It was described by Jinger et al. But you remember that the typical imaging is dorsal. Ventral subpial enhancement is also described very rarely, but dorsal subpial enhancement, central canal enhancement, and characteristic trident sign on axial contrast images. The contrast is very important. Without contrast, it's very difficult to make the diagnosis. They also undergo several stages. Initially starts with leptomeningeal enhancement only. Then it spreads along the perivascular spaces, causes edema, enhancement, and swollen cord. Then it normalizes and then undergoes atrophy. It undergoes 4 different stages. Another case, 5-month slowly progressive chronic spastic paralysis, bladder and bowel dysfunction. Here also you can see longitudinally extensive but not very, very obvious, very subtle signal changes. You can see that here in the especially cervical and dorsal area. And on the axial images, this bilateral symmetrical lateral column involvement here. So the patient had a very long-standing history, albeit well, vitamin E, everything was done and everything came negative. Copper, all those typical workup were negative. What do you think when you see, apart from those classical metabolic related, when you see this selective lateral column with a longitudinal extensive, and this patient will eventually go for atrophy of this cord, and they will have spastic paraparesis-like picture. Yeah, HTLV1 antibody was positive, and we all know that this is endemic in few areas, especially in Japan and these Caribbean islands near the equatorial Africa. And it's estimated up to 10 to 40 million individuals are having lifelong infections. The longitudinal involvement circumscribed to lateral column is very specific for this entity. It's also known as HAM, HTLV1 associated myelopathy. In the chronic form, the most common form, the hallmark radiological feature, if MRI is abnormal, is spinal cord atrophy, particularly affecting cervicodorsal region. Signal changes and volume loss is more pronounced in lateral and also may be seen in the posterior columns, mostly involving the white matter, but rarely involving the nearby gray matter or anterior nerve roots. Another case, 10 to 15 days onset of bilateral distal limb paresthesia and ataxia, positive Romberg, impaired proprioception and vibration sense. So this is easy. Similar to that paraneoplastic, it looks like. See this bright on DWA also. Some V shape. What is this? Yeah, this case was classical SACD, which can be a sequel to most commonly the vitamin B12 deficiency. MRI spine is normal in up to 60 to 80% of the cases. When abnormal, most commonly there is symmetrical high signal intensity within the dorsal column, giving a V sign or a rabbit ear sign. Signal changes typically begin in upper dorsal region, then usually it extends to cervical and lower dorsal region. Lateral column, or lateral corticospinal tract, and sometimes lateral spinothalamic tracts can also be involved. Often there is also accompanying cerebral white matter changes in few patients, especially perioccipital white matter in the brain, long-standing cases. Both spine and cerebral changes resolve after correction, and approximately half of all patients will completely recover. So there are various DDs, as I told you. Just to summarize, if you are seeing a myelopathy showing V sign, think about B12, previous history to exposure to nitrous oxide, copper deficiency, HIV vacuolar myelopathy, HTLV1, earlier tertiary syphilis also have shown similar cases. Then the vitamin E and spinal CTX and LBSL, these are other DDs. The list is growing, but these are the common things which we see. Another case, 48-year-old previously well, rapidly evolving lower upper motor neuron weakness and signs, bladder dysfunction, and MRI brain was normal. So this is very typical imaging finding. Plain T1, T2 axial, T2 sagittal. This is a post-contrast T1 weighted images. Axial post-contrast T1 weighted and coronal post-contrast. Look at the enhancement pattern and the signal changes in the T2 weighted images. And LETM, as expected, LETM looking like a very necrotic lesion because of this bright signal intensity, expansion of the card, and typical lentiform type of enhancement here. What is this? Tumor. It was a proved case of seropositive NMOSD. There were two signs which I was trying to show you. One was T2 bright spotty sign, and other sign was a lentiform enhancement sign and the post-contrast. LETM is very characteristic. Initially, all LETM started with this NMO only. Then we have a spectrum now of different etiologies. Only up to 15% of the cases may still have short myelitis in NMO. Lesions are transversely extensive. The definition for transversely extensive is involvement of more than 50% of the cross-sectional area. Central gray matter along the central canal is the preferred area. T2 bright spotty sign is seen in up to 30 to 90% based on the literature. But what exactly T2 bright spotty sign is, the signal intensity of the lesion, which is bright on T2, is more brighter than the surrounding CSF. So it looks much brighter than the CSF surrounding the card. That's why it is called T2 bright spotty sign. Because of necrosis and destruction of the card, the peripheral enhancement in the form of lens or a lentiform enhancement may be seen around this bright spotty sign. It can be seen in 1/3 of the cases, and both were seen in this case. So bright spotty lesions, which characteristically around the central gray, transversely extensive, usually cervicodorsal, necrosis. These are all the typical imaging findings. Though there are other manifestations, but in the card you should remember this. Now this is a young boy, previously healthy, presented with insidious onset of lower limb weakness with saddle anesthesia, urinary retention, and bowel incontinence. This is also a classical picture. I have marked it LETM involving cervical as well as the conus. And there is something called linear hyperintensity running through and through the central canal. It looks like a prominent central canal or a Hurley syrinx-like picture. And in the axial section, you can see central gray matter hyperintensity in the form of H. It's very classical, right? What are the DDs for this? Yeah, both MOG and many cases of ADEM can show this picture. So this is known as sagittal linear hyperintensity, SLH sign. And in the axial section, it involves central gray, that's why it is H-shaped. So H-shaped hyperintensity associated with sagittal linear hyperintensity. Specifically, it has a tendency to affect conus as compared to other diseases. Conus myelitis, whenever you see in a young patient, think about MOGAD. And pseudocentral, this is also known as pseudocentral canal or a pseudosyringe-like appearance because of involvement of the central canal. So, and if you give contrast, many may not enhance, but faint cloud-like or nodular enhancement may be reported. Even the meningeal, spinal meningeal enhancement like brain, it is also reported in the spine as well. In the brain, there are characteristic imaging pattern. One of them is fuel and flame, where unilateral hemisphere shows leptomeningeal enhancement, encephalitis like picture. Similarly, spinal enhancement can also be seen. So LETM is seen in up to 50 to 70% of the patients. Conus, as I told you, is very specific location. SLH, HSH, and may be seen in few cases of ADEM or NMO or MOG in up to 8% of the cases. Same maybe overlap. So another case, typical case, 74-year-old man, history of progressive weakness of lower limb for 1 year, long duration. Numbness in the bilateral distal lower limbs, right more than left, since 3 months. Urinary bladder urgency, reduced stream and incomplete evacuation, no constipation. Lower limb power was 3/5, sensory level at D12 level. What do you see here? These are the T2 weighted images, sagittal. You can see a long segment myelitis involving the lower cord, even involving the conus tip. If you see carefully, which we may miss, are the serpiginous phlovoids. These are the vascular phlovoids, not the CSF phlovoids on the surface of the card, especially on the posterior surface of the card as compared to anterior surface. So whenever you see that, please try to do a heavily T2-weighted images, confirm that these are abnormal vascular phlovoids, especially in an elderly male who presenting with progressive, long-standing history of progressive paresthesia, then pain, then early symptoms of urinary involvement, all should be spinal dural AVF unless otherwise proved. This is a category of patients, if you miss it, label it as myelitis or transverse myelitis, something non-specific, then as soon as they give steroids, this patient worsens. So any myelitis worsening with steroids in an elderly, think about spinal dural AV fistula. If you give steroids, water retention will happen. Already venous congestive myelopathy is happening there. On that you are given a steroid, further retention of the fluid and worsening of the symptoms transiently. Patient would have come walking, now he is not walking at all after giving steroids. Think about spinal DAVF. And enhancement may be sometimes scary. It can mimic tumors and it can be of variable. I will show you. You can do a tricks if you have a contrast enhanced trick images where you can demonstrate the vessels and probably from where the feeder is coming from, at what level, so that you can target that when you do a spinal angiography. Spinal angiography, preferably under anesthesia, is the investigation of choice. We should always do a complete study on both the sides, also the internal iliacs. If you don't get, you have to go to the neck vessels and the brain vessels also. Unless you do a complete angiogram, it is a STAF unless proved otherwise. So many times we see that patient keeps on coming with negative MRI, but MRI is suggestive of DAVF, but angio is not getting the exact site of fistula. That time you should always carefully check whether you have done a median sacral artery, lateral sacral arteries, neck arteries, even sometimes intracranial circulation also. So without that, it's always incomplete. And one more peculiar enhancement pattern which has been described is a missing piece enhancement. If you see that because of inconsistency in the venous drainage pattern in the spinal cord, it's that some part of the areas may be spared and some areas may be severely affected. Giving this, wherever abnormal areas are there, they may show enhancement, giving this typical missing piece enhancement. And identifying this missing piece enhancement is one of the important sign to confirm that you are exactly looking at a spinal DAVF apart from other findings. So don't get scared by looking at this type of scary enhancement. It can be seen consistently in DAVF also. So DAVF presents typically with the typical clinical and imaging features. Heavily T2-weighted images are crucial if you want to confirm that. Then high quality spinal DSA is the key. Otherwise, this patient keeps on getting repeated DSA. It's not easy to do a spinal angio. 3D DSA under general anesthesia is a gold standard for making the diagnosis and planning the procedure. It's elegantly treatable condition, especially with embolization. If there is a very close origin of anterospinal artery with the common feeder, with both the feeder as well as the anterospinal coming together, then patient may have to go for surgery. Otherwise, it's elegantly treatable through endovascular approach. Case number 9, 74-year-old lady presented with insidious onset of pain, weakness, both upper limb and lower upper limb for 1 week, numbness in the distal upper limbs, hyperreflexia, no fever. Treated with for carcinoma breast 3 years back. PET CT done 3 years ago was unremarkable. Declared as free from the disease. Diabetes, hypertension since 15 years. All other investigations were within normal limits. This is a T2 weighted image, T1 weighted image, post-contrast T1 weighted axial. What is this? Why I have drawn this diagram? Yes, somebody is awake. So there's some edema, longitudinal extensive edema and some lesion. But this lesion, apart from thick rind of ring enhancement, there is something which is spiking on either side, like this. See this typical picture? This is called as flame and rim sign. So flame is the one which is coming on either side, maybe upper or lower, or sometimes on both sides like this. And this is a thick rind of enhancement. Apart from this entire lesion is enhancing, but the peripheral rim is intensely enhancing with a spike on either ends. This is called as a rim and flame sign. If it is seen, it's very, very classical for intramedullary metastatic lesions. So think about it when you see that, though these are all rare conditions, because isolated spinal cord metastasis is extremely rare. It can be seen in CA lung or breast or melanoma and renal cell carcinomas. They generally enhance avidly. Peripheral thin region of increased enhancement is rim, and ill-defined enhancement extending above and below are the flame. So remember this sign whenever you see. This is another case where a 55-year-old man with the recent ACDF was done. You can see that shadow there. Anterior decompression was done and presented with 2 weeks history of left upper limb extremity pain, paresthesia, weakness, as well as global hyperreflexia. Then T2 showed longitudinal extensive myelitis-like picture, and this was the enhancement. Yeah, this is what is the definition of pancake and what does it indicate? A pancake enhancement is a typical pattern of enhancement seen in compressive myelopathy. Basically, they describe it as width equal to or more than the height of the enhancement. It's anteroposteriorly, it is longer than the vertical height, and it's just below the site of maximum compression. Or if you want to confirm that, you can do a dynamic flexion extension study and then see that worsening with the extension, then you can call it as compressive myelopathy. And these are the patterns which one should know, because in difficult, otherwise this patient will undergo extensive evaluation and painful process of diagnosis where you will not reach anywhere unless you give a clue. 7-year-old boy, 1 year history of subacute lower extremity weakness. Weakness progression, neurological examination revealed mild spastic lower limb paralysis, loss of vibration sense in lower extremities, and hyperreflexia in upper ones. No cognitive impairment or seizures. Very extensively involving the spinal cord, starting from the brainstem, going all the way. Even I have put a diffusion to show that selectivity of the restricted diffusion in a young boy. See this involvement of the lateral and the posterior column symmetrically going down all the ways, and scarred diffusion was not done, but the MRI brain of the diffusion showed that upper extremity there is some selective cranial nuclei showing restricted diffusion. This is very classical. No? What is this? LBSL. LBSL is autosomal recessive. It's a mitochondrial cytopathy. Autosomal recessive fashion caused by the mutation in the DAS2 gene present in the long arm of chromosome 1. So characteristic is bilateral symmetrical signal changes, especially in the cerebral white matter, sparing of subcortical U fibers, posterior limb of internal capsule, then the tracts and the trajectories of trigeminal nuclei, splenium of the corpus callosum, dorsal column and lateral corticospinal tract of medulla oblongata and spinal cord. Whenever you see, think about this entity, LBSL, as the name itself indicates, they will have elevated lactate levels in the CSF, and this imaging pattern is very characteristic. One more disease which I would like to tell you that rarely the biotinidase deficiencies, especially the late onset or the childhood ones, they can also have these LETMs, and they can also have a similar picture. So whenever you see a leukodystrophy type pattern and they have a spinal cord involvement, both of them should be kept as a differential diagnosis because it's elegantly treatable. And probably the last case I will show you, they will have other manifestations, cutaneous skin manifestations, optic neuritis, deafness, so many other things. It's elegantly treatable condition. So last case, background of a recent marathon runner and a short haul of flight, patient reported to have sudden onset pain in the posterior aspect of her left shoulder, followed by pain and paresthesia in her entire left arm, followed by left leg. After a few minutes, she experienced weakness in the left side of the body, then followed by right side. So there was a neck pain as well. This is typical that travel history, something exertion, and following that, this was a picture. See this? Extensive myelitis here also. Diffusion weighted image, contrast images, which was done later after a couple of days. And this was this. There is some arrow here, which I wanted to show that this particular disc is showing desiccation. To summarize everything, what will you put into a one diagnosis? Yeah. It's not infection. Fibrocartilaginous embolization, also known as nucleus pulposus embolization, is a rare cause of spinal cord ischemia. You could see that restricted diffusion, right, in the card and pencil-thin linear enhancement. Due to embolization of the nucleus pulposus material from the intervertebral disc in a retrograde direction. So these are extensively reported. There are a lot of literature in the veterinary science as well in this, especially in the dogs and horses. And there are so many case reports in the medical literature as well. Especially the female patients are vulnerable. They are seen in the extreme of age group bimodal incidence, either in the very young age adolescents or in the elderly. There were certain clues like adjacent humoral nodes, disc desiccation, minor trauma, most commonly in the cervical cord. Then the second most common region is conus medullaris, and typically in the territory of anterospinal artery. The propulsion of this nucleus pulposus material forcefully into this circulation, both they can go to venous or arterial route. When they go into the arterial route, they can cause this. Remember this sensitivity exists, and so many times if you do imaging on day one, you may not get the typical restricted diffusion or typical abnormality, but a follow-up imaging, especially with diffusion in the card, is very, very classical. We should try to do a follow-up at least after 24 hours, one more diffusion. If you have a suspicion and this typical abrupt onset history. So anterospinal artery infarct, linear craniocaudal strip of enhancement can be seen in subacute phase, involvement of anterior cells. It is not always symmetrical. In many cases, we have asymmetrical or hemicard involvement is also seen, or asymmetry is also seen. So especially the anterior cell with the diffusion restriction. These are the different patterns which is described. And note up to 50% of the cases, again, I am telling you, 50% of the MRI can be negative within first 24 hours. So don't jump to a conclusion. You may have to do a follow-up. So I think last case this is 42-year-old man, 18-month neck pain radiating down to the right upper arm, gradual weakness of both upper limbs. It's very typical imaging if you see this lesion. Card expansion is some dark signal intensity along the margin, card expansion here, and see the enhancement. This is actually a tumor with the cap sign. It's a spinal cord ependymoma, one of most common adult tumors, second most common in pediatric. Males more commonly affected. Tumoral and peritumoral cysts are very common. The cap sign is not very pathognomonic to ependymoma, can be seen in hemangioblastoma and paragangliomas also. So there's a summary chart. It's good to have this LETM master chart. If you should know that when you have a lateral column or a posterior column involvement, what are the DDs you should think? And when it is longitudinally and transversely extensive, what are the DDs should to have? When there are posterior lateral column, what are the DDs? And only anterior gray matter involvement, what are the differential diagnoses? Also, apart from that, you should have a list of diagnoses and what are the classical imaging findings and what sequence they are seen. If you have this in your reporting room or keep it as a chart, probably it may be required initially, but once you are familiar with this, you can do a reporting very easily to narrow down the differential diagnosis. So to conclude, misdiagnosis of myelopathies is a common. Although LETM is classically associated with NMOST, now it has a multiple etiologies as you saw now. Identifying the etiology is important for long-term treatment and prognosis. Radiologists should review the relevant clinical information and determine the patient demographics and the acuity of the symptoms. Must learn to recognize gadolinium enhancement pattern in myelopathies as you saw now. and which will focus investigation, decrease the unnecessary expenditure on the patient and reduce the morbidity. Timely and appropriate diagnosis greatly facilitate the patient management. Thank you. Any questions?
To elucidate your talk, sir, mostly nobody is having any queries.
No, that in fact, no, there one more point I wanted to make that actually yesterday only I saw that case. Residents came and the neurology resident told that, sir, arachnoiditis is there. So the infarct of the conus can, if you give contrast to them, actually all the roots can enhance. So we must know that it's not arachnoiditis. So, and second thing, the diffusion restriction is not actually specific to infarct. It can be seen in demyelination also, and it can be seen, you showed B12 deficiency also can have a diffusion restriction in the spinal cord. So diffusion restriction in spinal cord is not that as specific as we do in the brain.
Yeah, onset is very important.
Onset.
Pain onset.
Yeah, another thing which you mentioned, I am not very sure. I have seen few cases where diffusion restriction doesn't come, but the history is typical like a stroke. Within 5 minutes, everything has happened, or and started and everything happened, and then it cannot be demyelination. Looks like an ischemic, but diffusion restriction is not there. Is it comes a bit late?
Yeah, always late.
Yeah,
all my cases are like after 24 hours.
Yeah.
It's like lateral medullary syndrome.
But it's not very well described in literature that, like for acute stroke, within 10 minutes, diffusion restriction sets in brain. But
not in brainstem and cord.
Not in the brainstem and cord. So that's the point.
Yes, sir. Yes, sir. Yes, sir.
I had some experience where a spinal cord seems to be normal, not showing any lesion, and eventually it turned out to be dural AV fistula. Okay. So the first question is, can a dural AV fistula at some stage have a normal spinal cord also? And second is that if we do not see anything in the usual routine T1, T2, MRI, anything, including the subarachnoid space, we don't see those flow voids. Yes, does it 100% rule out DVAF? Can we be satisfied that there is no DVAF, or should we still rule it out by spinal angio when there is no clue on MRI?
It's difficult to completely MR negative, assuming that you have done appropriate imaging sequences, including ability to weighted, and there are absolutely no card changes and no flow voids on the surface. We cannot justify doing a spinal angiogram, first of all. And for an indication for a spinal angiogram, you have to have some suspicion towards spinal DF, classical history, age group, and you have some flow voids without card signal changes. Also, we have identified 4 cases last year where there were only flow voids, no card signal changes. Patients were asymptomatic. And even DAVF have these different stages. They initially present with prominent flow voids, they will be compensating, then they go for a decompensation phase when the reversal chances reduces, when myelopathy sets in, damage occurs in the card and the conus involves, bladder involves. So we have seen 4 cases where no cards changes, absolutely, only flow voids. The neurologist told us, why do you want to chase? Patient is fine. Then patient insisted to do angiogram. We found a lesion and we embolized them. They are doing well. Such cases are seen, but without card signal changes, flow voids, yes, we have to chase it. But without flow void, without card changes, we cannot make a diagnosis.
Thank you. Thank you.
Dr. Sarbes is one of the few candidates who has gone back to his pure academics. So he's into pure academics post his DM at AIMS Jodhpur, and he's very much academically oriented both from the teaching point of view and publication point of view. And he's very much interactive with the students and also highly interested in teaching and attending the seminars and delivering the lectures. I would like to continue with his 2 talks he has today and also a quiz session. So please go ahead.
So good afternoon, everyone. So over the next 30 minutes, we'll be discussing this. I always find it complicated. So this complicated topic of CNS vasculitis. So when we see a certain image and we are, like pretty sure 80%, 90%, this is going to be diagnosis. So those are the images that we are more interested in because you can give. But these are the diagnosis which we make in the discussion room, sitting with our peers, discussing the clinical history and examination details. So there are two terms here, vasculopathy and vasculitis. So when we say vasculopathy, it's a general term that is being used. And in general parlance, it means any disease affecting the vessel. If you ask a pathologist, they will say it is any pathology without inflammatory infiltrates, without any inflammatory cells in the wall, like an endothelial cell proliferation, thickening of vessel wall, narrowing of vessel lumen, fine, without inflammatory infiltrates. And if you have inflammation within the vessel wall, then we call it a vasculitis. So it is not primarily an imaging diagnosis. We can raise a possibility, and then whether that vasculitic pattern is because of an autoimmune or an inflammatory phenomena or an infective, that we will have to find it out. And always remember the vasculitis mimics. That is, in our country, the infective pathologies, they are more common than vasculitis itself. So when you classify vasculitis, you can classify them as primary vasculitis and secondary. Primary means it is affecting the CNS with no other systemic involvement. They are also known as primary angiitis of CNS. And secondary, it is secondary to etiology, which most likely been infective, HIV, radiation, and other things. Then you have mimics like atherosclerotic changes, neoplastic vasculitis, RCVS. So these are the mimics that we will be discussing in our talk. So this is the 2012 Chapel Hill consensus classification, which is the most commonly used. I hope it is visible, yeah. So here we are classifying the diseases based on the vessel size, right? So large vessel means, why are we classifying that? Because that will depend how you will be evaluating or examining these patients. So large vessel vasculitis like Takayasu and giant cell, it will be involving the larger vessels, renal arteries, the aorta itself, right? The common carotids, the subclavian. So you have an entire gamut. You can do PET scan in these cases because the large vessel walls are getting involved. Then you have medium vessel vasculitis like Penn and Kawasaki. The subgroup of patient that you send for DSA, if your patient is having medium vessel vasculitis, the chance of you picking up an abnormality on a DSA is very high. Talking about small vessels, these are vessels which are smaller than 300 microns. Now, the problem with them is that the entire DSA can be normal. Okay, so here we look at the immunoassay in the background of imaging finding to make a diagnosis, like IgA vasculitis, microscopic polyangiitis vaginalis, and all those things. Then you have variable vessel size vasculitis like Behçet's, single organ like PSCNS, and then you have other vasculitis, which is a cerebral systemic disease, of which the SLE, rheumatoid, and APLAs are more common. And then the entire list of infective pathologies causing vasculitis along with radiation and everything. This is what it looks like under the slides. You will have fibrinoid necrosis and inflammatory infiltrates within the vessel walls as well as thrombosis of the vessel. This is what is pathologically classified as CNS vasculitis. Now, what exactly happens in this patient? You have the agent causing inflammation, which can be an infective agent or a drug or radiation or an autoimmune factor, which leads to inflammation. Then these leads to infiltration of pro-inflammatory cytokines, which breaks the vessel blood barrier, and you have vessel wall enhancement. So this is the basis of vessel wall enhancement. And then this inflammation, it alters the vessel tone, which gives you the picture of vessel wall beading, the beaded appearance of vessel. The wall weakens, it forms aneurysm, microaneurysm. So if you find microaneurysms in a vessel, you are definitely dealing with vasculitis. It is one of a very kind of short finding that we get in vasculitis. Then these microaneurysms can rupture and they lead to bleed and hemorrhage, or these vessels can get occluded and you can get infarcts. So these are the different pathophysiological features that you get in case of vasculitis. How do we reach? So a request come to us, with a clinical suspicion. Mostly you'll have an acute finding like a patient comes with stroke or headache, or a subacute finding where a headache with a cognitive impairment or other such phenomena are there. Then the patient will have multiple blood inflammatory markers. You have to read that, you have to ask your peers, and you see your imaging in the background of whatever is provided to you. CSF is usually never normal. You have subtle raised protein or a mild pleocytosis that will also help you in diagnosis. For small vessel vasculitis, it is finally the elective brain biopsy that makes the diagnosis in most cases. So what are our hathiars or armamentariums? So for large vessel vasculitis, we can do MR, CT, DSAs, vessel wall imaging. Now all the scanners everywhere is equipped with sequences which we can run to do vessel wall imaging. PET is available for large vessel vasculitis. For small vessel, generally the angiographic techniques fail. You'll have a normal angiogram. There will be subtle signal abnormalities on MR, variable kinds of contrast enhancement, and a brain biopsy is invariably required for patients with small vessel vasculitis. So when you talk about vessel wall imaging, just a slide on that, you need thinner slice images. So you just have to understand, we are trying to image a blood vessel. The vessel has blood inside it. We need to suppress the signal of blood. We need to suppress the signal of CSF, and you need to have very thin slice, like for 2D sequence, go up to 0.4 millimeter thickness, and for a 3D sequence, a voxel up to 0.5 millimeter is possible to acquire so that we can image a vessel wall. I'm just giving you a option like whatever is run, like after the general sequences, you have to run a diffusion to pick up infarcts, SWI to pick up bleeds, a TOF MRI brain to pick up any vessel irregularity, P1 space fat suppressed and flow compensated in both plane and contrast study, and a DSA to confirm the vessel finding. So these are the basic sequences that we run when we're suspecting a patient with CNS vasculitis. So what do we see in brain? We can have, like in stroke, you have 4 Ps, because it's a vessel involvement. Here also you have parenchymal changes, some vascular changes, and some associated findings. Like look for perforator infarcts, look for lacunar infarcts, look for gray-white involvement. For large vessel vasculitis, you can have large territorial infarcts or watershed infarcts. Look for vessel wall enhancement, microaneurysm, segmental occlusions, and all. So let's look at the parenchymal changes. What you'll get, this kind of deep white matter changes, spot and dot appearance, or some of them getting confluent, the subcortical white matter getting involved, it's flare image, this kind of picture where you have infarct, this one looking like a chronic infarct over here, this one is subacute infarct. So infarcts of variable ages in a same patient, extensive white matter hyperintensity involving the subcortical white, the cortex, as well as the deep white matter. Identification of multiple microhemorrhages in bilateral hemisphere in different territories, and this kind of patchy starry sky kind of a diffusion restriction. So in the morning, if you remember, we saw a case of chikungunya affecting this kind of diffusion restriction. So those are all vasculitis. It's chikungunya or a rickettsia or a scrub, or even for that matter Klebsiella and Streptococcus pneumoniae is known to cause vasculitis. But in those cases, the cause is an infective pathology. It can be an autoimmune inflammatory process as well. These are the different parenchymal changes that you get. Look at the vessel. Now, if you see this particular case, this is the vessel, and this is the wall showing enhancement. So look for vessel wall enhancement. The vessel wall enhancement in case of vasculitis will be circumferential long segment. Circumferential long segment vessel wall enhancement is what we see. Look for this kind of microaneurysms. So you see a distal microaneurysm in a patient with suspected vasculitis, you are definitely dealing with one. Look for this kind of vessel involvement, vessel irregularity, narrowing of the vessels. So these are the different findings that we get. So I will be discussing cases based on the vessel size. I'll start with large vessel vasculitis, of which in our part of the country, Takayasu is a good prototype. So what is it? It's a chronic gangiomatous large vessel vasculitis that affects aorta and its main branches. It's a female predominant disease, and it most commonly involves the subclavian artery. When you send the patient for a Doppler study, you get this kind of wall thickening. So there will be diffuse thickening of the common carotid wall like in this particular case, and this is the intermedial thickness which has become very thickened. And this thickened wall is called macaroni sign. It's a named sign which we get in patients with Takayasu arteritis. This is a contrast enhanced MR angiogram. And if you see in this particular case, you see that there is differential narrowing of the abdominal aorta. You can see that the left subclavian is not getting opacified, neither is the left common carotid. You have this narrowing in the right subclavian artery as well. This is a CT angiogram image. So this is a coronal reformat. You can very well appreciate the wall thickening along the left brachiocephalic trunk and then following the left common carotid. I mean the right common carotid. This is the left common. This is the occluded left subclavian artery. And this is the axial scan very well appreciating the, demonstrating the thickening of the walls. You can see over here, there is thickening of the origin of left common carotid artery. So these are very well demonstrated on the CT images as well. If you do a contrast of fat suppressed T1 image, you can see the enhancement on the wall of the common carotid artery. Like in this case, the Peters part is getting involved, the cavernous segment. So the wall will be thickened and it will show enhancement on the post-contrast study. PET is very frequently used for the imaging or for the evaluation of Takayasu patient. They have a scoring system as well. So why is it important? Like whenever they send us a call to do a plasty or some intervention in this patient with severely narrowed artery, we tell them to start a treatment and get the PET activity down. And we treat the patient in a cold phase when the activity is lower so that the chances of complication or recurrence is less. So that's how we use PET in cases of Takayasu arteritis. The second prototype is again a giant cell arteritis. They have a 5 classification criteria. It's a disease of elderly, with presenting with new onset headache. They'll have temporal arterial pain and raised ESR. Now, we have something called a halo sign. When it is suspected, we can do an ultrasound of the superficial temporal artery. And if this wall is thickened more than 6 millimeter, it is considered as a thick wall, and this is called a halo sign. The STAs can be demonstrated on the post-contrast T1 images, where you can, I think, yeah, it is seen, right? This is the superficial temporal artery flow void. And you can see the enhancement around the STA. So this is called and this is the wall enhancement of STA, and even you can have larger vessel involvement like involvement of aorta. Many of these patients will present with headache with visual obscuration when your ophthalmic artery will be involved. So in such patients, it is very important to look at the abdominal, the angiograms and pick up this kind of wall thickening. And USG can be used as a bedside method for evaluation. The prototype for medium vessel vasculitis is PEN. So what is it? It's a focal pan-mural necrotizing vasculitis affecting the medium size arteries. It can involve any organs, and it is more common. It is equal sex distribution, commonly seen in 50-60% patient. Now, these patient has multi-system involvement. You will have skin involvement, renal involvement, GIT, CNS, PNS. So everything will be involved. So you'll get a detailed history of the patient, and always ask for a dermatological evaluation, because most of this patient will have dermatological manifestation as well. From imaging point of view, what do we get? We can get patients with variable ages of infarct, variable bleeds, then you can have stenosis and ischemia, and also spinal cord involvement. So let's look at this particular case. This young kid, he presented with headache and with a history of stroke. Now if you see here that there are multiple chronic lacunar infarcts in the basal ganglia and the thalamus. Look at this particular area in the flare. You have some certain gliosis in the right basifrontal region, which shows abnormal blooming on the SWI. So the patient has remotely bled also. Whenever you see this combination of chronic infarct, acute infarct, chronic bleeds, keep vasculitis as your differential diagnosis. If you see the TOF MRA, there is some irregularity of the distal MCA branches. This is the vessel wall imaging here. This is the plain T1. This is the post-contrast T1, and you can see subtle enhancement along the vessel wall at the distal right M1 segment of the MCA. And this is the angiogram. If you carefully see the angiogram, this is the ophthalmic artery which shows gross beading. This gross beading of the ophthalmic artery. Look at this particular thing. This is a small pseudoaneurysm over here. This is a focal puddling of blood in one of the frontopolar branches. And if you see this particular angiogram, this is a renal angiogram, you can see multiple microaneurysms involving both the renal artery. This is a classical case of polyarteritis nodosa. This is how they look. They'll have multiple aneurysms like this. A different case again. This lady has complaints of progressive asymmetric bilateral upper and lower limb weakness, from distal more than proximal, sensory motor, lower motor neuron, and upper motor type of weakness without bowel and bladder involvement. Again, same history here. You have multiple lacunar infarcts in bilateral basal ganglia, chronic infarcts, then this kind of microhemorrhages on the SWI, and this is the post-contrast scan showing enhancement in the infarct on the left side, which means it's a subacute infarct. This is a subacute infarct. This is a chronic infarct of variable ages. Sorry. Yeah. And this is the TOF that I have shown previously. We could pick up this small microaneurysm over here. It didn't show much of vessel wall enhancement, But in the post-contrast, we can pick up this enhancement, which is the enhancing microaneurysm in this particular case. Now, this angiogram was done. Now, I like to just point at this. This is a perforated aneurysm, microaneurysm over here. And just see this particular branch. This is a narrow branch which forms an aneurysm and then becomes narrow again. So this is the microaneurysm that I'm talking about. Again, a diagnosis of a medium vessel vasculitis was made in this case. We talk about small vessel vasculitis. Most of these are ANCA-associated vasculitis. If it is granulomatous ANCA-associated vasculitis, we call it Wegener's granulomatosis, or nowadays granulomatous with polyangiitis. If it is non-granulomatous, it is microscopic polyangiitis. And if it is eosinophilic granulomatous, it is called Churg-Strauss. So these are the three main candidates for ANCA-associated vasculitis. So our GPA is the one which is formally called Wegener's granulomatosis. This will all be ANCA positive vasculitis. They will have multisystemic involvement: skin, lungs, kidneys, sinuses, and
whole spine. If whole spine is not possible, at least cervical spine and screening of whole spine. So this is for spinal cord. Core sequences again, sagittal T2 weighted, sagittal stir. Again here stir is important. Normally stir in spinal cord is traditionally has been used for imaging the bones. So we see for marrow infiltration, fractures and all on stir, but plaques in general or demyelinating lesions stand out on stir. So sometimes we see lesions on stir that are not seen on T2. So please make sure that you obtain a stir, and usually stir will be obtained. You see the stir. You may see more lesions. You may see lesions that are not seen on T2. So the sites of MS lesions, so these four were the sites we were, within the criteria, this has been added in 2024. So we'll have to wait for the final publication, but this is the fifth site. So these are the 5 sites where lesions of MS are seen. So when we say MS and when we describe Dawson's fingers perpendicular to the ependymal margin and all, those classic descriptions are for the periventricular lesions. Criteria for periventricular lesions are in some section. That means you see all the sequences here are flare. So that is how important flare is, especially sagittal flare. This is 3D, this is 2D, this is 2D axial. So these are the kinds of lesions that we can see. A periventricular lesion is in MS is ovoid, or it may be round, but usually ovoid, and it should touch the ventricular margin here, and it should be like this. This lesion is also touching the ventricular margin, but we are not in a section like that. So the criteria is it should touch the periventricular margin for us to call it a periventricular lesion. I'm not saying it may not be it is not a multiple sclerosis lesion. For us to count that as a periventricular lesion, it has to touch the margin of the ventricle. So that is the definition of a periventricular lesion. Again, it is ovoid. It is ovoid because it is along the perivenule. It means it is along the venules. So that is why the lesion is ovoid. And these are to start with. As we follow up the patient, these lesions may become confluent. So then they may lose this whatever shape and size I'm telling. They are ideal, they're usually 3 mm or more. So the next or another common site is the corpus callosum. This is corpus callosum. They usually involve the inferior surface of the corpus callosum. Ischemic lesions will involve the superior surface of the corpus callosum. And one disease involves the central portion of the corpus callosum. Yeah, and like I said, all of you know more than what I'm going to say. So superiorly it is ischemic lesion, inferiorly it is MS lesion, and centrally is Suzak syndrome. So in MS, we see these are confluent lesions. When they start, they're usually single dots. So that is why a sign is described called the ependymal dot and dash sign. In this, dot is abnormal, dash is normal. So normal corpus callosum in between the lesions is the dash, and the dots are the demyelinating plaques. So once they become confluent, the dash becomes the abnormal. So that is not dot and dash sign. So initially dot is abnormal, dash is normal. So these are again confluent lesions. This is just to show the type of enhancement. So once the disease progresses, the lesions become confluent, then they lose their characteristic shape and appearance. Here additionally, we are seeing cortical or juxtacortical lesions. Here there is a difference between pathologically described cortical lesions and what in MRI we describe juxtacortical lesions. MRI juxtacortical means everything, the cortical lesion and the juxtacortical lesion also. Juxtacortical lesion is lesion that is here, if you see, lesion is in the subcortical white matter, but it is touching the cortex. It usually should be within 1 centimeter of the corticomedullary junction. That means the junction between the cortex and the white matter, the lesion should be within 1 centimeter, and it has to be counted as a juxtacortical lesion only if it touches the cortex. So this is a juxtacortical lesion. This is a juxtacortical lesion, Enhancement is usually like this is one of the patterns of enhancement. Usually the same open ring pattern of enhancement, even in smaller lesions is seen. We can see complete ring also. So, okay, juxtacortical we have seen periventricular, we have seen corpus callosal lesions. So this is what happens if when disease progresses. So they become confluent. We can see areas of rarefaction, that means complete loss of axons here. So they invert on flare. So they are appearing like they're more close to CSF signal than the lesion signal or even white matter signal. So this is where there is this, if we do T1, they will appear as black holes. So this is rarefaction of white matter. Then this is to show the patterns of enhancement. We can see linear, we can see solid pattern, solid disc-like enhancement. This is another thing. So anterior temporal involvement, this is a very common doubt that we get. I mean, at least I get asked many times, why is this not cadacil? This is, again, we see that this is in the periventricular region. It is touching the ventricles. This is how multiple sclerosis lesions of the anterior temporal lobes present. They will extend from here. Cadacil lesions will be, I have a picture I'll show. Cadacil lesions will be somewhere here. They are much more anterior temporal. They are usually larger and they will be usually symmetrical on both sides. And this is a lesion even in the anterior temporal pole. It is showing again open ring. This is one more lesion, one more demonstration of anterior temporal lesions. So we have seen 3 sides. Now this is the third side, that is infratentorial lesions. Infratentorial lesion also, the distribution follows the distribution of the venules. The distribution of venules here is such that the MS lesions is such that it is at the periphery. That means it will be around the CSF surfaces, that is on the surface of the pons or on the floor of the fourth ventricle. Small vessel ischemic changes in contrast are seen at the center. So lesions are on the surface. They may be near the exit of the fifth nerve. They may be along the course of the fifth nerve on either side, or they may be along the floor of the third ventricle. They may be in the cerebellar peduncles. In the cerebellum, there is no such predilection. So peripheral lesions along the near the exit of the fifth nerves on either side and along the intraparenchymal tract of the fifth nerves. So again, one very common thing that we have, I think all of us must have encountered, scan coming from outside, labeled as MS without means, often there is no clinical history, but patient is labeled as MS. So patient is worried and the physician is also worried. So white matter diseases versus MS. This is the slide itself is self-explanatory. So this is MS. So this is atypical. It's an open ring sign, central vein sign. These are all typical features of MS. These are typical features of small vessel ischemic changes. So 3 to 5 mm, 3 to 15 mm. So larger lesions in small vessel ischemic changes, they're usually confluent. For MS to reach this stage takes a very long time. But long-standing MS can reach this stage, but we will have additionally, we will have gross atrophy. If someone reaches this stage, parenchymal atrophy will be gross. What is not seen is, microbleeds are not seen in MS. Central vein sign will be seen in MS. I'll show what central vein sign is. U fibers are not affected in small vessel ischemia. U fibers are affected, juxtacortical lesions that I told. U fibers are not affected in small vessel ischemia, but they are affected in MS. Again, continuing with the same thing. So like I told, pontine in infratentorial lesions, vascular and small vessel ischemia usually affect vascular. We will identify because they are in territories paramedian or whatever. Small vessel ischemia distribution is like the distribution of osmotic demyelination. It is at the center. MS lesions are discrete and usually at the periphery. So these are some slides. You just have to spend some time. These are Green flags, these are red flags. These are not bad. So there are few slides like this. Red flags are clearly not MS. Not periventricular lesions are lesions which are plus minus, and the green flags are lesions that are MS. So green flags we have already seen. Red flags are not MS. This is typical lesion of periventricular distribution, but parallel to the ventricular lining. So this is seen in NMO. So this is along the ependymal lining. So this is our CADASIL. This is any kind of edema or vasculitis can have this pattern. Not periventricular lesions are things that are like frontal caps. These are small vessel changes. So they are in the periventricular location, but they are not ovoid. They are not in the characteristic shape of Dawson's fingers. So same thing for cortical and juxtacortical lesions. This we see commonly. Single dot in the subcortical location. It is not touching the cortex. It is more than 1 centimeter away from the cortex. These are what we used to call ubios. Now we describe them and leave it. These are typical juxtacortical lesions. This is one of the sequences that I was saying to demonstrate cortical lesions. When we try, we don't get these beautiful images. So this is involvement of, the MS lesions are usually like this. The cortex and the subcortical white matter is involved. They will not be so beautiful, so nice dots. Again, these are other lesions that we commonly mistake for MS. Again, a lot of them. So this is a mnemonic for your red flags in MS. This is, I think, from Nature Reviews Neurology. So it is called mimics. Red flags, if these features are there, we generally don't diagnose as MS. So meningeal enhancement, this is not to say that leptomeningeal enhancement is not, leptomeningeal pathology is not there in MS. Leptomeningeal pathology is there. It is reported in MS. It is known in MS. We don't see on radiology meningeal enhancement in MS. So if meningeal enhancement is there, we should look for alternative diagnosis. Indistinct lesions, increasing means over a short period of time. Macrobleeds or microbleeds. Infarcts. If we see the diffusion restriction in a case of MS, we have to think that it is an active lesion. So it should not be in a vascular territory. It should be in a distribution that is corresponding to typical locations of MS. That is showing restriction, then it becomes an active lesion. Cavities, complete ring enhancement. S is symmetric lesions. MS lesions are not symmetric. Sparing of U fibers. U fibers are commonly affected in MS. Siderosis, spinal cord, and that is elitium, we have already seen in the previous talk. So this is central vein sign. Central vein sign should have been reported long back because we knew the pathology was around the venules. So this is flare, this is SWI. So these are blown out to show. So central vein sign, there are three, we have to, the criteria for diagnosis, we have to see it in at least two different sections. And the venule should be seen as a linear structure in at least one section. It should not be a dot in all three. So SWI is a volume sequence. SWI is a 3D sequence. We can reformat in all planes. So the vein should be seen in at least two sections, and it should appear as a line in at least one section. When I say section means axial, coronal, or sagittal. So this is again another demonstration of central vein sign. So this is the plaque. The hyperintensity is the plaque. The line at the center is the vein. So we are demonstrating central vein sign. Someone has actually measured and shown that the lesion size has to be about 3 mm or more than that. So central vein sign, the importance of central vein sign is differentiating from other lesions, other etiologies. We have a lesion like this. We are not sure whether it is MS lesion or not. So central vein sign is seen, it becomes more likely that it is MS. And in the latest criteria, if we demonstrate more than 6, if we count more than 6 central vein sign, even radiologically isolated syndrome we can diagnose. I mean, it is all debatable now. In the first, suppose what we used to call radiologically isolated syndrome, if it in that scan we are able to show 6 lesions with central vein sign, then we can diagnose, or the patient can be labeled to labeled to have MS. This is another sign again. It is like MOG again. Lot of papers will come out on this hot topic. So this is paramagnetic rim lesion. So this is seen because of deposition of iron in the microglia or macrophages surrounding the plaques. So presence of microglia around the plaques indicates ongoing inflammation. So why this is in consideration? Because for us to demonstrate activity on imaging, we have only contrast enhancement and diffusion restriction. Or if we clearly demonstrate between 2 scans, there is increase in some lesion or new lesion has appeared. This presence of this indicates that even if lesion is not increasing, there is ongoing disease activity. So that is its importance, and that makes it important for us to recognize this. So this is again flare. This is phase image of SWI. Again, this is available in all machines, almost all machines. We just have to look for it. So we see the lesion. This is the plaque, which is hyperintense at the center. Surrounding that, there is a black rim. This may appear black. This appears black in our machine. It may appear white in your machine. So this is how paramagnetic rim appears. So this is a lesion here. This is again, all this is blown out to just show that we have to look carefully, otherwise we will miss. We'll have to adjust the window to see it. So this is a very classic paramagnetic rim lesion. We see multiple other dots here. This is another lesion here, but it is not as nicely seen as this. So we actually need to have a lesion of a sufficient size to see paramagnetic rim. This is, we are going into gray area here. This is also paramagnetic rim, but we are not able to see it as a rim. It is similar to like we have smaller ring enhancing lesions that appear as disc enhancing lesions. So smaller lesions with peripheral enhancement appear as solidly enhancing lesions. It is something similar to that. So in MS, this is what is called chronic active lesion. Chronic active lesions criteria is, there are 3. We have the translocator protein PET that is not there with us right now. So there are 2 things left, that is on MRI. We have slowly expanding lesion and paramagnetic rim lesion. So this is the continuum of slowly expanding lesion and paramagnetic rim lesion. Paramagnetic rim lesions over a period of time can expand, they can remain the same, or later the paramagnetic rim actually disappears. Then you have non-paramagnetic rim lesions, which is active expanding, or this is decreasing and this is increasing in the lesion size. So this is the concept on which further material will be generated over the next couple of years, I think. So that was about the brain. Next is the spine. It again, all of you know more than me. So short lesions. Can we see LETM in multiple sclerosis? Yes, we can see LETM. All these lesions, if they become confluent, they will become LETM. So LETM can also be seen in MS. Well, that's when all these lesions become confluent. And we are seeing, you see the sequences being demonstrated here. I have not shown you. This is STIR, this is STIR, this is gradient. So STIR, again, the message is STIR is more sensitive. It shows the lesions. It may show more lesions. It may show MS lesions better. So cervical cord, again, cervical cord is the common site. Single level, mostly posterolateral, discrete smaller lesions. enhancement pattern is almost similar to what is seen in the brain. But compared to the brain scan, demonstrating it is means uncommon to see enhancing lesions in the cord. So this is what has changed in imaging in the 2024 McDonald's criteria. So we have central vein signs. Presence of 6 or more lesions with the central vein sign is a diagnostic marker. Paramagnetic rim lesions and another imaging biomarker. Optic nerve has been added as a site. Optic nerve lesions we will see in contrast with NMO and MOG. So optic nerve has been added as a 5th location. Optic nerve involvement can be demonstrated on MRI, OCT, or VEP. This was being considered for a long time to be included in the criterion. Finally, it has been included. Dissemination in time, this criteria is no longer mandatory. Patients with RIS can be diagnosed with MS if they meet dissemination in space. That means you demonstrate in multiple locations, and they have either CSF biomarkers or 6 or more central vein lesions. So DIS criteria plus CSF biomarkers or MRI showing 6 or more central vein lesions. This we have seen. This is a Suzak syndrome, central lesions. This is just to show the potential DDs of MS. So our favorite topic. So anything looking like ADEM, now the fashion is to call it MOGAD. Actually, to some extent, we are right also. So the moment we see this, the difference is clear. The lesions are ill-defined. They are larger. They can be anywhere. If we see this, if we saw this scan maybe 7-8 years back, we would call them ADEM. So optic nerve involvement. So this is coronal post-contrast. This is diffusion trace, and this is ADC. There are a few things that we have to pay attention. So optic nerve is enhancing. The nerve sheath is enhancing. The nerve is showing restriction. We are seeing restriction in the papilla also. So the same ADC is decreased. So papillitis is there. Optic neuritis is there. Optic perineuritis is there. Anterior optic nerve is involved. So here there is no involvement. So anterior optic nerve involvement, long segment with papillitis and in enhancement of the optic nerve sheath. We can see fat standing around the sheath as well. So this is again, this shows bilateral optic nerve involvement, papillitis. If we see, it is means we see this more frequently than we expect actually, papillitis. So bilateral, anterior, so chiasma involvement favors NMOSD, anterior optic nerve involvement with papilla involvement favors MOG. So white matter lesions we have seen, basal ganglia, thalamic lesions we have seen, optic nerve lesions we have seen. Now you see a patient who has diffusion restriction like you would expect for encephalitis, post-ictal changes, something like that. There is cortical and leptomeningeal enhancement. On flare, there is cortical swelling and hyperintensity sulcal effacement. So you will only tell. Flames like what we, okay, let us not go there, flames. So this is sulcal hyperintensity that we see with, like what we see in meningitis. So this is what flames and fuel is. So flare variable means flare hyperintensity may or may not be there. Unilateral enhancement of the leptomeninges. So post-contrast shows enhancement, but flare signal intensity is there or not there, we don't know. So, but the one we saw that it was bilateral. Flames is this. So these patients present with seizures, so we would be tempted to diagnose them as encephalitis, or we would consider seizures as the primary event and the findings that we see as post-ictal changes. So it is important to remember that they can be due to MOG also. So moving on to, we have seen parenchymal lesions, we have seen optic nerve lesions, now cranial nerves, and then we'll go to spinal cord. So this is leptomeningeal. We have seen leptomeningeal enhancement in the cerebral cortex. You can see leptomeningeal enhancement in the brainstem also. There is cranial nerve enhancement. This is, Sarat sir showed this case already. And if you see your own cases, I am sure you will find some of the cases that show this. So there is, here, this picture shows a few findings. Conus is a preferred or a predisposed location for MOG involvement. In this patient, there is involvement of conus. There is, if we see this, we'll call this as a prominent central canal. So there is pseudo-dilatation of the central canal. Same thing in a slightly higher location. That means in the lower dorsal cord. Again, this is a stir sequence. This is T2. This shows the enhancement of chorda equina. So there is radiculitis, there is enhancement of conus medullaris, hyperintensity, swelling and bright signal within the conus medullaris. Just to reinforce the point, this you have seen already. The H pattern that is seen in the axial images. This is a summary. So paramagnetic rim lesions. So I'll highlight the atypical things. So paramagnetic rim lesions can also be seen in NMOSD, but they are rare. Central vein sign is seen in less than 10% cases of NMOSD. They are seen in more than 40% cases of NMOSD. Optic nerve bilateral lesions in MOGAD or NMOSD, that doesn't mean that they have to be bilateral always. Unilateral typically in MS. They are longer lesions. Optic nerve lesions in MS are shorter. Anterior optic nerve head swelling and perineural sheath enhancement that we have shown, they are seen in MOGAD. This is NMOSD. So this is the distribution of lesions. This red thing is the distribution of lesions. There, if you see, they're all around the ventricles. They follow the distribution of the aquaporin 4. So these are the typical prototypes of the lesions that we see around the fourth ventricle. So MS lesions we told where they used to be located somewhere here or all around this. NMOSD lesions are around the fourth ventricle, in the middle cerebellar peduncles, medulla, periaqueductal gray, lateral walls of the third ventricle, and in the splenium, parallel to the or along the ependymal lining of the ventricles. So same lesions. These are even more bizarre or poorly defined than MOGAD lesions. So the diagnosis of MOG and NMOSD is typically approached from the spinal cord side. Diagnosis of MS is typically approached from the brain side. So NMOSD and MOG will be eletians. And in eletium, if we have one spinal cord or one patient showing two different or two discrete eletium lesions, then the patient is more likely to have MOG. So what does this show? This. No, this area postrema involvement in NMOSD. You are more advanced than what I expect also. So this slide sir has already shown. So I'll skip this. These are, this is what? Missing piece. Post-contrast spinal cord MRI showing missing piece in enhancement seen in spinal dural AV fistula. Sir showed just a while back. So these are some high yield points. Acute NMOSD lesions may be hypointense on T1 weighted images. This is the first time someone is telling about T1 weighted images in spine. Other diseases may be isointense, or we don't generally see unless it is post-contrast. But if it is hypointense on plain T1, it is more likely to be NMOSD. Up to 15% NMOSD patients can have short lesions. So that is a substantial number. 1/6 or 1/7 of cases can have short lesions, may not have LETM. Chronic NMOSD will have short lesions plus cord atrophy. So short lesions, you are suspecting NMOSD, but they have short lesions plus cord atrophy, it may fit the diagnosis. NMOSD is thoracic more than cervical. MS is cervical. Then bright spotty sign, that means a part of the lesion within NMOSD that whose intensity matches that of CSF is seen in NMOSD. Up to 16% of NMO cases can have brain lesions similar to MS. And multiple cord lesions, this I already told, multiple cord lesions in LATM are more, favor a diagnosis of MOGAD more than NMOSD. I think this you have seen, I think you will be seeing it once every month. So this slide is important, we'll end with this. These are imaging factors that portend a poor prognosis in any case. So this is MS. So cortical lesions, higher number of lesions or higher volume of lesions, reduced gray matter volume, lesions located in the corpus callosum or motor tracts, 2 gadolinium enhancing lesions. Whatever is highlighted are features that suggest that that particular patient might have more disability as we go forward. So in MOGAD, that is extensive leukodystrophy type lesions or extensive cortical lesion in pediatric patients. Brainstem involvement at the same time when we see spinal cord involvement, and reduced cervical cord area and conus lesions. Okay, I think we'll stop here. Any questions?
To see this central vein sign, because
Microbleeds. Phase image we used to see to differentiate calcifications from microbleeds. That image we have to see this paramagnetic rim line. Yeah. So we don't have to ask specifically to do a particular sequence. While seeing, we have to select the image and see.
3D flare availability now. Every scanner has 3D flare. That's not. I published a paper in 2008 on using why not do 3D flare every case. There are two advantages. In case of MS, you have a fat saturated 3D flare. You don't need to do a separate optic nerve imaging. You can actually very well see the optic nerve on 3D flare. Second thing is that point was made about the enhancement, the meningeal enhancement. Actually, in multiple sclerosis also, especially when the juxtacortical lesions are present, there are papers which have shown that post-contrast 3D flare shows meningeal enhancement. It is a meningeal process is there. So that only thing we are not able to see, but with the good sequences and contrast, we can actually see that. So these are the 2 points. So, and cranial nerve enhancement, actually I have also observed many cases because we do post-contrast 3D. A lot of people don't do 3D, they do 3 planes. But it's better to do 3D. You actually, if you start observing a lot of cranial nerve enhancement, can be seen even in demyelinating analysis.
Therefore, 70, whatever literature mostly we see, the central vein sign and the paramagnetic rim, that's on 70. So how good can we do? I mean, see them in on 3T and all?
These are what I showed are on 1.5T. So, like I said, all of you have 1 or 3 Tesla. I have 1.5 only. So, it will be seen. Maybe we will not see. If they are seeing 20 lesions, maybe we will see 10. But we will see.
Because in the criteria also we have to have at least 40% of those lesions showing a central
So
vein.
yeah, that is what. So when it becomes like we are counting numbers, lesions, then we have to get it on a 3T. Then we don't know if we are missing. Suppose 6 lesions of with central vein sign are there. So it is better to get it on a 3T. No, then the doubt will always be there. I think they will once the criteria becomes in force, it comes, then they will only recommend it to be done on 3T.
Diffusion weighted image, and you see the rim you will start seeing some of the lesions showing rim kind of hyper intensity on trace images, not the ADC. Look at the trace images, you will have a rim kind of appearance. There's a green journal paper, you can actually read it. So that actually helps us a lot comparing to the ischemic lesions or other lesions which we see. So I think that is not very well described in the literature, as well as it is not given much emphasis on the reviews as well as in the criteria. But actually that's a much more useful tool when you have in doubt whether it's a demyelination or it's not a demyelination. You can see that green journal paper is there on it.
I hope that audience are attentive only. I request Dr. Ullas to go ahead with the next talk. He's keen in both diagnostic and interventional neuroradiology, and also in pediatric neuroradiology also. So Ullas, yeah, you can take over the next talk.
Yeah, good evening, everyone. I think we have had extensive talks, and my talk is actually covered by the other two speakers who have already done it. So it makes my job easier to probably only summarize the findings which have gone till there. And probably in the next few minutes, we will see how actually we try to make out whether we are dealing with something of a demyelinating disease or a vasculitic type of pattern of disease. So we will make it a little different. We will try to see the basic imaging sequences and what we look at that to make a diagnosis of a vascular lesion or a demyelinating lesion. So we have seen extensively what the findings primarily are. So the interest of my talk would be obviously for the introduction, the rheumatologic disease can present with neurological symptoms. I'm talking on secondary autoimmune diseases which present in the brain. MRI obviously is the choice. There are advanced sequences which I see as only of limited clinical use, but obviously for the research work it is important. So outline would be to see what the imaging patterns are, what are the overlaps with other conditions, what are MRI specific sequences, imaging findings which we can have, how to differentiate from primary demyelinating disease. I think that was covered in the last this thing, and specific disease entities, few of them, few new things which we might see, and their imaging findings. And then the last thing would be we give drugs. So what are the implications of having these drugs as a pointer? So the first one, let's see the pattern. So the pattern of involvement is meningitis. So if meningitis is there, two things come into mind. One is infection versus inflammation. Obviously a complicated one in terms of having a cranial neural involvement intraparenchymal lesions in terms of small tuberculomas, abscess. All of these would point more towards a infective etiology, but most of these we do not see if we see with aseptic meningitis. We saw that anti-MOG antibody disease having that flare hyperintense signals. So it usually is a bland meningitis. It's a simple meningitis, that would be the one. What we have to use is the flare sequence, which we just discussed about, and why not just T1? Because you see the difference between the meningeal enhancement which happens in the sulci is very hardly seen on this. And if you see this is almost there. And what can confound is the presence of the veins, which can be seen here, which will be suppressed in cases of the flare. So if we are suspecting any of these vasculitis or infection, we need to take a 2D post-contrast flare. That is the bare minimum post-contrast sequence for us to show. The next pattern is obviously stroke. What type of strokes can happen is one of these is the large vessel stroke, which can happen with or without or any kind of autoimmune disease. But obviously these people are predisposed, so we can have a large cortical infarction that way. Or it could be multiple of these, so many lesions which we saw in the today's sessions itself. This type of pattern becomes important. We have to start thinking that we are probably having a perivascular phenomenon. Perivascular phenomenon can include infection, it can include inflammation, it can include lymphomas. So any of these processes can happen with a perivascular type of involvement. So what I would try to recognize on this image is this is a perivascular involvement, be it of any cause. In fact, in this case, it was because of an infectious vasculitis and meningitis. This is a case of SLE, and you can see this type of cortical ribboning which happens, say in the insular cortex, orbitofrontal, medial temporal. This type of pattern also you can get in a case of autoimmune disease. And these are immunosuppressed people. And this need not always be the normal autoimmune encephalitis pattern. We have to be very keen to follow this up and see that these are classical areas of asymmetrical involvement. Symmetrical involvement, we talk about metabolic, toxic, viral, those kind of stuff. When you see this asymmetrical involvement, this is classical for herpes simplex virus. Obviously, they are immunosuppressed people, so they can have this type of involvement. This is just to bring about, this is not a case of any of these, just to show the different type of pattern where you can have the entire cortical ribboning pattern, which can be seen with a classical history of HIE, but this, in a case of the prion disease, also you could have all of these cortical ribboning sign in a classical case. So if you see something like this, probably we are not dealing with vasculitis. This is to show that this type of pattern we might not see with vasculitis, whereas you have a symmetrical globus pallidal involvement, you have symmetrical involvement of dentate peridentate areas, and then you have the cortical involvement, which is symmetrical. So think about toxic causes, such as in this case it is carbon monoxide poisoning, whereas in this case it could be the methotrexate or ionized isoniazid type of toxicity, and in this case, it is a excitotoxic injury in terms of, say, hyperomonic encephalopathy, which can happen with liver failure. So these patterns are not common with what the topic which we have. Again, further going ahead, you see symmetrical white matter involvement like this, the deep white matter, you see the posterior limb of internal capsule, some of the cortices in the posterior aspect are bright. Probably, again, we're dealing with metabolic conditions like hypoglycemia, and this is not any of the autoimmune disease. This, classically, osmotic demyelination. And then you see this can be associated as a non-specific finding, clock or the transient splenic lesion, which can happen with many of these patients as well, because any seizures itself can cause it on change of medicines, and there are a whole bundle of causes for that which could happen. So these are some of the non-specific patterns which we can see with this. Obviously, when you have something like this, you start thinking about a few differentials in terms of again, an encephalitic pattern which can happen. You see the flare here and the orbitofrontal areas. And then after follow-up imaging shows resolution. And then you know that when this comes up, you think about encephalitis, you think about post-ictal changes, ASL, arterial spin labeling sequences would help us to show that hyperperfusion and all. And in the follow-up, and obviously you have the clinical background there where the patient improves, we are talking about post-ictal changes. So these are non-specific patterns. We saw some of the specific patterns on diffusion, and now we are seeing some of the other patterns which can be seen, which will not be seen with the autoimmune diseases. And when you have this type of a pattern, now you have a large mass-like thing in the periphery of that lesion being showing diffusion restricting. These are type of the lesions which we start thinking about the tumors in the brain, and these are not any of the autoimmune diseases which we talk about. Again, you can see here, this is classically in the white matter, diffusion restriction, and very avid enhancement. This happens, then again it is not vasculitis or secondary demyelination. We are talking about a classical condition of lymphoma in such a scenario. So these are some of the classical appearances which you would get. And you can get sometimes like this, a complete diffusion restriction within the lesion central part. You can get the ventricular margins showing that diffusion restriction. And sometimes none of these things are there, just a multi-layered appearance. And these are all different types of infections which can confound the findings. So this is the case of abscess, this is ventriculitis, this is a toxoplasmosis, those type of thing. And when you get a tumor-like lesions like this, and we have seen some of the open ring, the peripheral ring enhancement, peripheral ring diffusion restriction, we probably are dealing with tumefactive demyelination. So just to show that not all patterns can be easy to diagnose, and many a times we are kept in confusion of what that could be. And many a times this finally will require even biopsy to even prove what we are dealing with. So these are some of the the patterns which are not usually seen with demyelinating diseases. So the next pattern, so we finished meningitis, we finished the diffusion restriction, the strokes, and which could be potentially not the findings which we see with autoimmune disease. And the next common pattern which we see with this type of diseases is the press. So vasogenic edema involving posterior parieto-occipital area is a classical description for press. Okay, but you should also be aware of this type of central variants of press where you have the thalami being involved, the pons and the MCPs being involved. These are the central variants of press. Obviously, the clinical history is there. And in an autoimmune patient, if there is a variation in the BP, which could very likely be, these could be the scenarios which we could see. That will also get us to identify atypical press, which is actually the real life scenario. More times you see something like this, which is happening. It might not be the posterior predominance. It might be the anterior predominance. As we saw, it could be the thalami being involved, patchy basal ganglia. Why not this a small vessel? If you do a follow-up, they actually resolve. And then it was a transient edema, which has come up and gone with the process of press. Classically, cytotoxic restriction is not defined with press, but you could have them. And you could also have the bleeds, which are not commonly described with these type of entities. So one has to keep in mind the atypical presentations of press as well when we deal with such situations. Another important sequence which we talked about, the primary demyelinating disease, was SWI. And SWI also remains as a very, very important sequence for us when we diagnose anything about the vasculitic pattern. And these type of microhemorrhages, when you start saying, first thing should come into the mind is the, again, the perivascular type of involvement, the vasculitis type of picture. So SWI plays an important role for us to diagnose. Similarly, you can see this type of enhancements. I think we saw this type of enhancement in also the prior sessions, that the subnodular enhancement in these distributions of deep white matter, some linear type of enhancement, these are classical for perivascular distribution. So what I'm trying to stress is we try to use these sequences not for the diagnosis. Many times we cannot probably arrive at the diagnosis, but to understand the process of the pathology which we are dealing with. So I understand that this is probably a perivascular type of involvement which is happening in terms of, it could be the diffusion restricting, some of them are not diffusion restricting, as we saw in the prior and this type of microhemorrhages and the enhancement which happens like this makes me think that we are dealing with something of a primary perivascular process, which could turn out to be any of the vasculitis which we saw as the prior sessions have shown us. The next presentation or complication which we could have is obviously the CVT. You can see the hyperdense sinuses, the juxtacortical hemorrhages, the lobar hemorrhages, and here you can see the bilateral thalami involvement. So in an obvious clinical setting of autoimmune disease, these are the complications which we can expect. I'll run through these slides because everyone knows about all of these. So this is just the absence filling of those sinuses to say that it is the sagittal sinus thrombosis. So in a clinical background, we may have to include the MR venogram and also the cortical. What is most important is actually to pick up the cortical vein thrombosis. And for that, we again go back to SWI. So if you see in the MRV, we might not pick up that vein only because obviously it is not filling, so we don't pick up that vein. What gives us the information is actually the SWI. Or if you have done a plain CT, the hyperdense cortical vein, Those are the important things which we look for. And in the 3D contrast, which we do normally, the gradient sequence which we employ, we see the veins being filled up. And if we demonstrate that this vein is not filling up, that's when we say that it is cortical vein thrombosis. So this is a challenging situation. The routine CVTs are picked up easily, but in cases of cortical vein thrombosis, we need to have this type of specific sequences for us to identify. The next pattern, we have seen it already, that we can employ the vessel wall imaging of the black blood sequences, which we talk about. The concept is you suppress the luminal flow, you also suppress the surrounding structures so that you see the structure which is in between them, that is your vessel wall. I will not go into all the details which we have already talked about. We basically are looking for vessel wall enhancement, as we see in this case, the vascular narrowing correspondingly, which we see with the angiograms, say it was normal, then becomes narrowed, and then further remains that way. So what I'm trying to say is we employ each of these sequences, and each of these sequences give critical information for us to come to a final diagnosis. The other presentation could be plexitis. You could do and this is the case, you probably have specific imaging techniques in terms of the nerve, 3D nerve view, which we call as in the Philips machines, which gives us a very good imaging of the plexus. This is one of the manifestations. It could be mononeuritis, it could be mononeuritis multiplex. Any of those is possible. So we need to sequence that particular nerve and take those particular nerve-related imaging. It could also be the muscle involvement, which we saw in the earlier class in the morning today. So all of these are other type of presentations which all of the secondary autoimmune disease can also present with. And obviously, you can have brain atrophy. In a young patient, you see brain atrophy, then something should strike you saying that some chronic process is happening. It is an important finding. That leads us to further investigation, further thought process for us to see what else is happening, and that helps us. This probably I could skip because most of this is already dealt with. So when we saw that, you see this, now you're seeing the flare hyperintense lesions, you saw the importance of other sequences of SWI, and this is what does it tell us? How to differentiate it basically from the primary demyelinating disease. If I have to summarize what we just saw in the prior session was, how do we differentiate multiple sclerotic lesions from other lesions is, the lesion should at least be 3 millimeters. They should be perpendicular to the orientation of the ventricles, and they usually are commonly seen in and around the temporal horns, in contact with it, not in the subcortical region. And you have all these classical patterns of Dawson fingers, the dot and dash sign, all of these which help us to say that these are multiple sclerotic lesions. So these are few of the points which you have seen again in the last thing. If you start seeing microhemorrhages on SWI, if you see large infarcts or small proper infarcts on diffusion weighted imaging, then you should start thinking that this is not your primary demyelinating disease. It is still vascular process, but not primary demyelinating disease. That gets me away from those diagnoses. That is why this is important for us to know. NMOSD we saw, what could be the spectrum of involvement. Why that is important? We can have combination of all of these secondary autoimmune diseases with NMOSD. So these are all possible with NMOSD. So you could have both the antibodies being positive, the primary, whatever the vascular condition is, along with that you could have the NMO, the aquaporin antibodies being positive. So a combination of these involvement is always possible. Again, how to recognize, we have just gone through it, so I'm just not going to discuss all of these. The most important thing for us to remember is anywhere around the surface of the ventricles is where we get the NMOSD lesions. So if we get a lesion in any of these areas, the first thing should for us to strike is the NMOSD, and that's why you have those 5 clinical patterns as well. You have the optic neuritis, you have the long segment myelitis, you have the diencephalic involvement, you have the area postrema type of involvement, and you have the cerebral hemispheric type of involvement based on the classical distribution of these aquaporin antibodies. So let's now see some of specific disease entities. So till now, we have covered basically imaging sequences, each sequence, what we need to see for, how to differentiate it from the primary demyelinating disease, and a few of the specific entities which we'll go through. So if an elderly male comes with, say, a lot of these microhemorrhages, and you see this type of white matter signal changes, not much of enhancement. When you see this cortical, subcortical, this many type of hemorrhages, obviously you have to rule out infection, the other types of all the inflammations. If you have ruled out everything, what should strike to our mind is the cerebral amyloid angiopathy related inflammation, the CARI. So this should be kept in mind in any elderly patient who has this type of lobar, the microhemorrhages at the cortical, subcortical junctions, after having ruled out all the other causes. Again, just to try to show some other rarer conditions, when you see something like this, T2 hypointense and enhancement, so when you see T2 hypointense, first thing which strikes to me is the benign etiology for me. In terms of it could be, say, a granuloma, it could be a TB, it could be a fungus, it could be, when I say granuloma, it could be any of the non-infective chronic granulomatous conditions like sarcoidosis. All of those will come into mind, and the enhancement. So we could probably potentially prevent a biopsy in such a case. Obviously, this is a case which is taken from the literature, which is hypothalamic amyloidoma. Just to say that we may not get this diagnosis, but we have enough clues to say that this is a benign etiology and it might not be a tumor, and it could primarily represent an inflammatory process. The other pattern which we see here, so you can see a lot of pons being involved, the MCP being involved, the cerebellum being involved, a lot of edema, and you see this variegated small enhancement, you see nodular enhancement, you see some of bigger enhancements also, areas of bigger enhancement. When I see this, first thing, when I look at the FLAIR images or T2-weighted images, it looked like a tumor for me with a lot of this edema being there and those kind of stuff. But with this type of enhancement pattern being there, again, this type of pattern is suggesting me that it is a vascular process. That is what first thing comes into my mind. And then when I say this, there is vascular involvement, this type of thing, the pattern which is actually described is for something called as clippers. See, chronic lymphocytic peripontine enhancement responsive to steroids. So that condition is one thing which comes in mind. But there is a definition for clippers. All clipper lesions, again, will not be more than 3 millimeter. But here I have lesions which are more than, say, 3 millimeter in size, and there are other additional findings as well. So in a classical setting, such as hepatosplenomegaly, pancytopenia, I would start thinking of the hemophagolymphohistiocytosis as a condition for this. So you see, first is to recognize the pattern and then to come to the diagnosis, because it's not always possible to come to a diagnosis. Again, when you see this type of involvement, you see white matter is looking like in a vascular territory. Obviously, diffusion is negative, so it is not stroke, we know that. And then you start seeing something dotty enhancement like this, linear enhancement. Again, just suggesting that it is a vascular process for me. Or if I say vascular, or an inflammatory process for me, and this is slippers, the brother of clippers, right? So these type of, we can think about this type of rarer diagnosis because of the pattern of involvement. Another case, you can see this, the diffusion not appearing bright, but not truly on the ADC. And you again see this type of enhancement, brush-like enhancement which is happening. Again, suggesting it's probably autoimmune and an inflammatory process. And this is actually GFAP astrocytopathy. You see, I might not get into these type of diagnosis, but I'm trying to focus on the primary pathophysiology which could happen, leading out to say that it is something of this sort, and then we start thinking and sending these antibodies if we have to pick those up. Again, you can see here a lot of diffusion restriction, this white matter changes and this. So this turns out to be lymphoma. Again, so everything is not the same, but it is looking the same. A lot of probably these type of diffusion restricting foci were odd for any type of vasculitis. So again, it's a vascular phenomenon, but the etiology could be different. And obviously, we might have to investigate, take a biopsy for us to prove what we are dealing with. You can have multiple, just focal isolated lesions, and these are common. We have seen with many of these secondary autoimmune patients. This is just focal vascular lesions. They do not look like the normal small vessel ischemia also, but they are not real infarcts also. They're somewhere in between. I don't know exactly how to tell them, but these are lesions which can be seen with cases of your autoimmune disease like SLE. They represent focal small vessel ischemia. You can get vasculitic infarcts, like the proper diffusion restriction with basal ganglionic involvement, peripheral enhancement, or you could get bilateral basal ganglionic involvement with enhancement. In such case, you think about autoimmune encephalitis as a condition. So there is a difference. You saw the pattern difference between the last slide and this slide, that was vasculitis. whereas this is an autoimmune encephalitis associated with SLE. You could also have a proper other type of autoimmune encephalitic pattern in terms of the medial temporal lobe being involved and this type of enhancement. Again, suggesting, these type of things you don't see with tumors. If you start seeing something like this, you're probably dealing with inflammatory cause. And in an appropriate setting of secondary autoimmune disease, you're talking about an autoimmune process here, like what we have seen here. This was also, I think, shown. You can have small segment lesions, demyelinating lesions, enhancement. All of this is possible. Like an MS-like lesion with SLE myelitis, you need history for us to diagnose all this. Again, just to show the pattern of these vascular lesions, you see this lesion goes away with steroids, but another lesion comes up somewhere else. Fleeting opacities. It has to either be an inflammatory disease or a lymphoma again. Lymphoma only to come back later. If it is a demyelinating lesion, it usually responds. So again, Behçet's disease, I think we had discussions on this. The classical sites of involvement, thalamomesencephalic area, the same type of enhancement. You see the enhancement is something consistent, which we have seen with all these cases which is going on. And in appropriate clinical setting, this would represent Behçet's disease. You start seeing this type of enhancement along the surface, along the brainstem surface, and then you have the conus and the cauda equina nerve roots enhancing. You have this in the cord signal changes which is happening. So this all can be seen with, and this is something like a trident sign which we saw with sarcoidosis. This had also mediastinal lymph nodes and then turned out to be sarcoidosis. So these are the typical signs, again, which we have seen with the prior this thing, the classical appearance of the posterior, this thick enhancement, and then you start seeing the central enhancement. So these are called as the central canal enhancement or the trident sign, which is seen with the sarcoidosis. Scleroderma, you have a pattern of scleroderma called as the localized scleroderma, the N-coupe de Sevres, where you can have ipsilateral, say one focal area of volume loss of the tissues, which could include the bone, which could include the soft tissues. You could have this thin rim of dural enhancement, which could happen, and some amount of these signal changes within the basal ganglia. So a particular pattern related to scleroderma. Again, history becomes very important when you deal with such things. You look at this white matter signal changes, you might think, this we are dealing with an inflammatory type of a process. Again, one of the odd points is to have a lot of these meningitic type of picture, and with a classical history of travel going to, say, usually the North America and those kind of stuff, and the people have come from there, fever, polyarthralgia, all those things can lead to a diagnosis with, obviously, if you have a characteristic skin rash which comes up, you're talking about the Lyme's disease there. The other basal wall imaging need not only be for the intracranial portion, we can also employ it for the extracranial or the superficial temporal artery, which you have a grading system for it. In case of giant cell asteritis, this is how I'll just for your reference here, you can go through that. So you could employ it for that. It is not only about, as we saw, the patterns. It is not only related to brain, nerves, and muscles. It can also be the orbital area. It could be the nasal area. It could be even the, say, laryngeal areas. All of these give us some information. If there is a amyloid, it can have tracheal focal thickening. So all of those are possible in an appropriate clinical setting. If you see something like this T2 hypointense, that is again a sign for benignity. Again, a sign for something inflammatory. Something granulomatous. And once I see that with a classical, say, saddle deformity of the nose, the septal perforation, and then you see this T2 hypointense lesion inciting an inflammatory response and edema around it, and this type of enhancement, rarefaction of the paranasal, the ethmoid trabeculae, and a cavitatory lesion. This we have seen it in the morning. This is a classical case of Wegener's granulomatosis. So just to say that these are all secondary autoimmune, there are clues for us to diagnose that these are secondary autoimmune diseases. This is just to show the mnemonic for what could lead to nasal septal perforation. Again, you start seeing the stalk becoming hyperintense and thickened, and T2 hypointense. You are dealing with autoimmune most of the times. So with that condition, you see some inciting edema because of this thickened stalk. And we saw that in the CT scan, which Dr. Sarbesh had shown. The same thing can happen with the MR. You have the pancreatitis, you have the cholangitis, you have this mesenteric paniculitis, and you can see this characteristic periaortic soft tissue, which is there. Whenever all of these constellation of symptoms come, we start thinking about the IgG4 type of diseases. When you see this is a distance between the anterior arch of atlas and dens is increased on the flexion study, meaning to say that there is atlantoaxial instability. Along with that, you see an enhancing pannus, with the contrast here and the T2 star hyperintense signals. You know you're probably dealing with something of an inflammatory pannus, which is very characteristic with rheumatoid arthritis. Now, these are certain specific findings which we see with secondary autoimmune disease. This again is an interesting thing, which you see that you have this erythematous lesions with central porcelain white dot, if that happens, and these people have vasculitis as features of the GI tract commonly. And along with that, you can see inflammation within the brain. Again, the characteristics are the same till now, whatever we discussed, but the clinical scenario is different. In such a scenario, this is actually called as the DiGeau's syndrome. So vasculitis of the GI tract, skin, as well as the CNS involvement. So let's see about the few drug-related things. So here you see the two different types of cases. You see the pontine edema, and then you see the parieto-occipital, this thing. Similar type of parieto-occipital involvement, but both are different. This is actually PRESS, which we saw, but this could be progressive multifocal leukoencephalopathy because of immunosuppression. Again, what is the difference between the two? You see that there is actually volume loss happening, whereas here it is more of edema. There is effacement of the sulci, and in a characteristic setting of immunosuppression, this is what is quite common to have a progressive multifocal leukoencephalopathy. It can have at the rim like a demyelinating thing, because there is active demyelination happening around the rim of that lesions. It can be seen as diffusion bright signals. Usually they are non-enhancing. Some degree of enhancement might be there in few of the cases. Once you start seeing such patients, when you have this type of periventricular diffusion bright signals, we saw one of the case in the morning. Obviously, one of the things to rule out would be CMV ventriculitis, but that would be more properly diffusion restricting. But these are just diffusion bright signals, and not only the periventricular areas, you can actually see the cortex areas are also being involved. In such a scenario, immunosuppression patient, we should start thinking about immune suppression related lymphoproliferative diseases. It need not be always lymphoma, but lymphoproliferative disease, any of the spectrum is possible. And you see this type of a lesion after treatment, that you have a thick rim of enhancement, central necrosis, and you have some other lesions as well here. When you have this type of diffusion bright rim, and actually in the perfusion, it is seen as low signals. Now these, if barring the perfusion signals and those kind of things, if you see this type of lesion, we would probably call this as glioblastoma multiforme. But in a case of immunosuppression, we should understand that this is a case of lymphoma. In an immunosuppressed case, the lymphoma lesions will actually have central necrosis. They will not behave the same like what we saw with the first slides, where it was avid enhancement of the lesion, but we see something like this, where you have the peripheral enhancement. Last few slides. So MS-like lesions can also be caused by a few of these drugs, TNF-alpha inhibitors. So there are 5 of them which can breach the blood-brain barrier and lead to these MS-like plaques. So MS-like lesions can be seen with few of these drugs. This is again, you can see that there are a lot of microhemorrhages, diffusion restricting foci, flare hyperintensity. It's just saying that both bleeds as well as stroke-like pattern is happening with these type of drugs, meaning to say thrombotic microangiopathic pattern is happening with such type of drugs. Just to show the various background, and there has been reports of even autoimmune encephalitis being caused by few of these drugs. Coming to the last slide, you see something like this. Okay, I don't think personally I will be able to diagnose this as CNS vasculitis. Finally, you need, after having gone through whatever we saw, if that pattern is what we get, probably we are able to say that this is vascular phenomenon and probably come to a diagnosis based on all the inputs which we have from different organs and obviously the clinical outlook. But certain cases when it is like this, we are not sure. I think we should not hesitate in doing 2 things. One is PET and one is brain biopsy. We should be aggressive enough to go ahead and do these 2 things, because few times I have seen in 2 of our cases where it was a PET. When we found a gut lymphoma presenting the same type of pattern in the brain. Okay, and you can, in this case, it is taken from the literature, which shows it to be actually a vasculitis. So these type of differences, I don't think it is easy every time for us to diagnose just on the imaging. So we need to go in, just to importance this, that we have to go in early and get the tissue when we are in doubt. Thank you.
Coming to the last concluding session, followed by a quiz also. So,
Cursor is not. Cursor. Okay, so we'll have two back-to-back sessions. So we'll be finishing this. This is just primary imaging in cranial and spinal vascular malformation, how different kinds of vascular malformation they look and how we diagnose them, followed by the quiz or the guess the image section, where we'll be seeing some 20 cases. So in this presentation, I'll be talking about brain vascular malformation followed by spinal vascular malformation. We talk about any vascular malformation in brain, we talk about them existing without shunts and with shunt. So vascular malformation without shunt, it is usually a DVA, that is a developmental venous malformation, capillary telangiectasias, cavernomas. Okay, so these are malformative vessels at the level of capillaries. With shunt, the shunt can be located at the level of dura, when we call them a dural AV fistulas, or it can have a nidal type, that is inside the parenchyma, where it is called AVM, or it can be located on the pial surface, when we call them as pial arteriovenous fistulas, pial AVFs. Now let us go ahead with intracranial vascular malformation without shunts. So what's a DVA? A DVA is also called a venous angioma. It's basically an anatomical variation. So if you look at a cortex, if you see the cortex will be drained cortically into the suprachiasmatic sinus, right? And the deep white matter will be drained by the deep venous system into the vein of Galen. When you have this kind of malformation where the deep system is being drained by the superficial system or vice versa, we call it a developmental venous anomaly. So what do you get? You basically get this kind of radially arranged medullary veins. They will be drained by a single collecting vein into the cortical venous system. So they are the most common intracranial vascular malformation. The estimated incidence is around 2.6%. That is, if among 100 of us, 3% will have an existing DVA. So it's not always pathological. But it's common location around the frontal horn of lateral ventricle and fourth ventricle. Now, if you have multiple DVAs, there can be syndromic association like blue rubber blab syndrome, and there's something called your mismatch repair deficiency syndrome. It's called cerebral cavernous malformation related mismatch repair deficiency syndrome, which have a very high propensity for high-grade gliomas. So, what is the natural history? We report them in the report. I mean, in our description. But 98% of them are incidentally detected, and they are asymptomatic. Whenever they are symptomatic, it is because of hemorrhage or infarct. What can be the association? DVAs can coexist with cavernomas. They can coexist with sinus pericarni. Because it's a malformation, the surrounding cortex can also be malformed. So if you are looking at a patient of drug-resistant epilepsy, look at that cortex which is in relation to the DVA. You might find a cortical malformation, or it can be a part of HST syndrome. It is hereditary hemorrhagic telangiectasias. So this is what happens in the DVA. So you have an inflow and you have an outflow, right? So if there is an stenosis in the outflow, that is the DVA, the draining vein, if there is an stenosis, the pressure inside it rises and the DVA can rupture, or they can have cavernous formation, the cavernoma formation, right? So let us look at some example. This is how a classical DVA looks. You have this multiple tubular radicals, then they are drained by a collecting vein into the petrosinus in this case. So this is a classical example of a DVA. This is the same patient's, I mean, this is a different patient's angiogram where you can see this is the multiple radiating vessels that drain by a collecting vein into the deep venous system. So what exactly happens? So whenever there is DVA, if there is a chronic elevation of pressure within the DVA, it can lead to microhemorrhages around the DVAs, and that will form cavernomas. So sometimes DVAs can be associated with cavernomas, and if they are coexisting, that should be separately reported. Like in this particular case, if you see, there is a DVA which is involving the thalami, and in this particular case, the patient has developed a cavernoma of the left thalamus. So the association is well known and it should be separately reported. A different case, this patient came for evaluation of drug-resistant epilepsy. So you can see that there is a cavernoma which is located in the region of left amygdala. Apart from that, you can see multiple radiating tubular radicals with a DVA formation in this particular case. So DVAs can be associated with cavernoma, and the cavernoma can become symptomatic their way. Okay, this is a slide that I've taken from this journal where they have described association of multiple DVAs with constitutional mismatch repair deficiency syndrome, and in these particular associations you'll have high grade malignancies being associated with multiple DVAs. So multiple DVAs, we should always report them separately. The next common malformation is intracranial capillary telangiectasias. These are basically malformed capillaries which will show enhancement, and they are mostly asymptomatic. This is the classical location in the center of the pons. And if you have multiple of them, there can be association with HST. They're mostly incidental. They do not require treatment. We can mention them in the body of the report. They don't require to be mentioned in the impression. Okay, so this is a classical example. You can see this faintly enhancing area in the dorsum of the pons, which is showing blooming on the SWI image, a classical example of hereditary, of capillary telangiectasias. From here, the lesions will start becoming symptomatic. So this is a cerebral cavernous malformation. What are these? These are enlarged blood-filled. So these are enlarged blood-filled endothelial compartments within a venous capillary vascular bed of the central nervous system. They are basically malformative vascular hematomas. 80% of them are sporadic. If you see multiple cavernomas in the same patient, think of familial association. So you can have CCM1, CCM2 or CCM3 genes, and if you find multiple cavernoma in same patients, screen the spine, use a GRE sequence, you might find multiple cavernomas in the spine itself. Okay, so they're the third most common vascular malformation. 2/3 of them are solitary, 1/3 can be multiple, and it can occur at any age, and 10% of spontaneous intracranial hemorrhages in children are accounted for by cavernomas. So 26% they present with hemorrhage, and they have an annual hemorrhage rate of 2.5%. This is similar to AVM. So if you have a incidental cavernoma, the annual incidence rate of bleed is around 2.5% per patient year. So look at this different examples. There is a Jabromsky classification for cavernomas. Type 1 is like a subacute bleed, which will appear bright on T1 and T2 and will show this kind of peripheral blooming. Type 2 is the classical popcorn ball that is described with cavernomas, where we have differential signal intensity both on T1 and T2, and they will show subacute blood. And this is a classical popcorn appearance in a type 2 cavernous malformation. Type 3 will have this kind of a chronic hemorrhage-like lesion, and a type 4 will have punctate microhemorrhages in bilateral, in extensive distribution. So this is a Jabromsky type 4 lesion. So let us see some varied presentation of patients with cavernoma. So in this case, if you see, there's a small lesion over here. It is being represented. So small lesion over here, and you can see different ages of blood with layered appearance. So this is a example of cavernoma in the amygdala, which is responsible for patient's seizure. In this particular case, you have a cavernoma in the periaqueductal area. And this is causing compression on the aqueduct of Sylvius, leading to obstructive hydrocephalus. This is a different patient where this young kid presented with paresthesia and myelopathy. You have a dorsal column involvement over here with a cavernoma. Now moving ahead, so we are at the level of capillaries now. Now we are moving to the malformation with shunt. And the classical example or classical prototype of it is a brain AVMs. So what is a brain AVM? It is basically a nidal type of vascular malformation. There the artery and vein, they communicate to each other without the capillary system, rather than you have a nidus. And this and in this area there is no capillary bed and there is no normal brain parenchyma. So that is a classical description of a brain AVM. You will have an artery followed by a nidus, followed by a draining vein, which will go into the venous system. So these are again rare diseases, 1.3 per 1 lakh population. They usually present in young adults, which is 20 to 40 years of age, and they are responsible for 3% of hemorrhagic strokes in young. They're usually solitary. If you find multiple AVM, think of genetic conditions like Rando-Osler-Weber syndrome or Wibben-Messin syndromes. The annual risk of hemorrhage is around 2 to 4% per year. So cavernoma and this they are almost similar hemorrhagic risk. How do they present to you? If they come with bleed, they will come in the emergency with a hemorrhagic stroke. They're mostly a young patient with bleeds. Some of them can present with epilepsy, seizure. When these AVMs are cortically located, they can lead to gliosis and hemosiderin deposition or ischemia in the bed, leading to epilepsy. Some of them can have chronic headache. Some can present with focal neurological deficits. So how do we diagnose them? If a patient presents with bleed, they are mostly done a CT scan in the emergency, followed by a CT angiogram for the evaluation of the angioarchitecture. And if the patient presents with seizure, it is mostly the MR that will be done. So let us look at some example. If you see a young guy coming with bleed in the subcortical or non-hypertensive territory, which means non-ganglionic hemorrhages, like in this particular case, it's a cortical bleed. Always suspect a cause for the bleed, right? Just a hemorrhage will not do. We'll have to do a CT angiogram and demonstrate a vascular cause for the bleed. So any atypical location of bleed, it should be further investigated. So we go ahead with CT angiogram in each case of cortical bleeds, and like in this particular case, we can identify a deep AVM which is being drained into the deep venous system. In this particular case also, you have a occipital hemorrhage in this particular case, and here you can see a nidus, a vein, and this is the feeding artery. So it's an AVM with a bleed in atypical location. This patient, young patient with cerebellar bleed. Again, this is not a common location for hypertensive bleed. This is neither an age for hypertensive bleed. And this case also we can demonstrate an early draining vein, which was suggestive of an arteriovenous malformation. Take home message from this slide is, if you have bleed in a young patient in a location which is not known to have bleeds and hypertensive, go ahead with CT angiogram to demonstrate a vascular malformation. Now, if the patient presents with seizure disorder, or if you're planning for resection of this vascular malformation, the patient undergoes an MR. So apart from the conventional sequences that we do acquire a TOF MRA for the nidal evaluation, a post-contrast gradient-based T1 weighted image, which will give a beautiful depiction of the venous anatomy, and an ASL. This is particularly useful in post-treated patient to identify residual AVMs or residual draining veins. So just to show how does a vascular malformation will look in different sequences. So this is a patient who already had a bleed. You can see a gliosis over here. Then you can see this hyperdense nidus with internal calcification. This is the T2 weighted image where multiple flow voids are seen. This flow voids, which is corresponding to this hyperdensity. And you have this flare image where it's showing perinidal gliosis. So this perinidal gliosis is generally responsible for seizure activity. This is the TOF MR image, which shows the nidus nicely. And this is the ASL, which shows the hyperperfusion around the nidal area. So what to do in a suspected lobar bleed in young? Do a CT brain and CT angiogram. If positive, find DSA, and then you can do the angioarchitecture evaluation. If negative, you're thinking of a tumoral bleed, go ahead with an MRI brain Okay, demonstrate whether it's tumoral or not. If negative, go ahead with DSA. If both of them are negative, you have to repeat the same process again after 4 weeks. So atypical bleed should not be left alone. There has to be a cause for it. It can be identified at the first admission or at the second admission. And if the patient has come with epilepsy, headache, or focal neurological deficit, go ahead with MR and consider fMRI if the nidus is located in the eloquent cortex, because that will help you in planning the resection. And DSA will remain the gold standard for the angioarchitectural evaluation of all the arteriovenous malformation. So this is just to show an example of fMRI in brain AVM. So this is, you can see this nidus which is located bang on the motor cortex, on the leg area, and this is the right foot motor task, and this is the hand motor task, where both the areas are getting delineated. So fMRI does have a role. The surgeon will know where is the eloquent cortex. Now, one differential for this is cerebral proliferative angiopathy, where you have a diffuse nidus without any early draining vein with intervening parenchyma. So unlike AVM, there will be intervening parenchyma without an early draining vein, and this etiology is called cerebral proliferative angiopathy. So they are not similar to AVM, and they are difficult to treat otherwise, because this cannot be surgically resected. They will have normally normal brain parenchyma intervening the nidus as well. So all right, whenever you are doing a DSA for these patients, we have to acquire a 6-vessel angiogram and at a higher frame rate. If a 3D is possible, it should be acquired, and we should comment on these few items. Where is the AVM located? What are the arterial feeders? Tell the number of arterial feeders. Give the size of the nidus. Is it a compact nidus or a diffuse nidus? Mention the if there is any intranidal or a feeding artery aneurysm with the AVM. Talk about the venous drainage, single vein, multiple vein. Is there any stenosis in the draining vein, or is the main draining sinuses are thrombosed? So all this information is what we are supposed to tell on the DSA. So most of the AVMs are supratentorial in locations, and we can classify them as cortical, subcortical, cortico-ventricle, that is from cortex till ventricle, or choroidal or deep, that is around the ventricular system. Only 15% of them will be infratentorial. So this is some of the examples. This is a cortical AVM. As we show, this small AVM located on the cortical surface. This is a cortico-ventricular type of an AVM, extending from the cortex till the ventricular margin, cortico-ventricular, or a choroidal or deep type, where the AVM is located inside the ventricle or the deep structures like thalamus or the basal ganglia. So just to see, like in this particular case, we are seeing the arterial anatomy. In this case, is a compact nidus being fed by one dominant and one non-dominant feeder. In this particular case, we can demonstrate an intranidal aneurysm, a large venous varix to start with. Okay. In this particular case, kind of a diffuse nidus with multiple arterial feeders. So all these have to be reported. The size of the nidus is very important. The size less than 1 centimeter is called micro. Smaller AVMs are 1 to 2 centimeter. Moderate is 2 to 4. Large is 4 to 6. And more than 6 centimeter is a giant nidus. Like this is a classical example of a compact nidus. Everything is small, and all the nidal elements are very compact together. And this is the example of a diffuse. And as the nidus become more diffuse, it becomes difficult to treat such cases. This is a micro AVM. You can see this is being fed by a lenticular stride branch with this very small nidus, which will be less than 1 centimeter, called a micro AVM. Again, similarly for the venous drainage, describe the venous drainage. It's a single draining system. Is it draining in the cortical venous system or into the deep venous system? Because AVMs draining in the deep venous system has a poorer prognosis. And after the reporting, we try to put the patient in this grading system called the Spechel-Martin grading system, where we take 3 things in characteristics: the size, the location, and the pattern of venous drainage. If the size is less than 3 centimeter, we give it 1 point, medium 2 point, and large 3 points. If AVM is located in the eloquent cortex, they get 1 extra point. That is, if it's in the motor cortex, the language area, or the brainstem, so they get 1 extra points. And if it is draining in the deep system, it get 1 point. So SM grade 5 is a kind of a high grade AVM, and SM grade 1 is the low grade AVM, which can be treated both surgically as well as by the endovascular route. Now, from the parenchyma, we are going to the pile surface, which is called pile AVFs. Here, it's again a fistulous type of cerebral, vascular malformation, where the fistula is located on the pia surface. Okay, not on in the parenchyma, on the pile surface here, there will be an artery and a vein communicating on the surface of the brain. Now, these are rarer than the brain AVMs. Like this is only 0.1 per lakh population or 1 to, and they are more common in the pediatric population. So we have two types of pile AVFs. We can have a galenic AV fistulas or a non-galenic AV fistula. So this is a classical example here. You can see on the T2 brain, you have a flow void which is located at the cortex of the brain. This is in the superior parietal lobule, and surrounding it you have a gliosis and some cystic area. This is the TOF MRA which shows the flow void over here. This is the DSA where the artery seems to communicate to a pouch followed by a vein, right? So there is no nidus here. The artery directly communicates to a vein, and these malformations are usually on the surface. This is a classical example of a pile AV fistula. The other thing is this is a that was a non-galenic case. The other classical example of AV fistula is a vein of Galen malformation, which is generally an intrauterine diagnosis nowadays. All people, they undergo multiple ultrasound scans, and these are diagnosed antenatally here. The median present cephalic vein of Markowski, it persists, and you can see this kind of vein of Galen malformation. Now, these malformations are usually fed by the choroidal arteries, which can be anterior choroidal or the posterior medial and posterolateral choroidal arteries, or via the limbic arch, that is the distal branches of the ACA. Okay, so you will have a large pouch. So this is a classical example of a vein of Galen malformation. You have a large central pouch, and the patient will have associated hydrocephalus. Now, this hydrocephalus is because of two reasons. There is a chronic venous hypertension, which is not allowing the CSF to drain downwards, number one, and number two, the kind of mechanical obstruction you do. Here, the treatment of choice is not directly putting a shunt, rather first occluding the shunt and then thinking whether a shunt is needed or not. If directly a shunt is being put without taking care of the vein of Galen malformation, it will cause something called a melting brain syndrome, where the entire cortex will start to shrink because the ventricle will keep on enlarging. Coming to DAVFs, so you have a fistula at the level of parenchyma. You have a malformation in the parenchyma, that was an AVM. Then on the pile surface, that's pile AVF. In the same pathology, the fistulas are located on the dura. It is called a dural AV fistulas. Now this, unlike the other two, it's a disease of little elderly population, that is 40 to 60 years of age. They're mostly solitary, and the clinical feature will depend on the location. If it is around the transverse sinus, it will cause tinnitus. If it is causing a lot of venous hypertension, it can cause bleed. It can cause proptosis if there is anterior venous drainage. A lot of cortical reflux, if present, it can lead to malignant DAVFs, which has a bleed rate of 8 to 10% per year. How exactly DAVFs happen? They are usually a sequelae of CVT, which can be traumatic, which can be infective, or can be secondary to a prothrombotic condition. So these CVTs, they lead to local hypoxia. Okay, hypoxia around the occluded sinus, which will cause the release of angiogenic factors. There will be neoangiogenesis and leading to formation of DAVFs. Plus, a chronic venous hypertension can lead to opening up of pre-existing dural AV fistula. So this is how a DAVF is formed. Mostly, it is secondary to a CVT or an infection. So let's look at some examples. This 70-year-old gentleman, hypertensive, presented with severe headache and decrease in visual acuity. So what we see here is an atypical location of bleed again. This is a temporo-occipital bleed on the right side. A CT angiogram was done, which shows a peripherally or a cortically located a large venous varix in this particular case. And if you see the CT angiogram only, this is an occipital artery on the left side. Hope it is seen, this small dot. And this is the occipital artery on the right side, which is appearing visibly enlarged. So when you are seeing this kind of bleed and you see one side external carotid system being super enlarged, think of a cortical, think of a DAVF. In this TOF is a sequence of choice, because here you can see the dilated occipital artery with transosseous feeder, and then this channel on the other side of the calvaria with this venous pouch. It's the classical imaging appearance of a dural AV fistula, which is being picked up on a TOF MRA. Whenever you are suspecting a DAVF, ask your MR technician to acquire a whole brain. Sometimes you can have fistula high up in the superior sagittal sinus. So acquiring a conventional circle of Willis TOF MR will not help. The entire brain should be acquired. So this is the same patient angiogram. You can see the multiple feeders which are from the occipital artery as well as from the petroscomusal branch of the right middle meningeal artery. A different patient, again a 65-year-old, kind of a similar presentation, again a bleed on the right side, but in this case we have intraventricular extension again. And if you see the source images of CT angiogram, here also you can see that one-sided occipital artery is quite enlarged, and this is the thick MIP reconstruction where you can see this crowded vascular channels along the right temporal lobe. And then this is the T2 weighted image where you can see this edema around the right temporal occipital region with multiple flow voids, and TOF always helps to show this kind of transosseous feeders and this channels along the venous sinuses, which is quite diagnostic for dural AV fistula. This is the angiogram again. So this is the selective IMAX run where this is the occipital artery is enlarged, as well as the petrous commercial and the petrous branches of the middle meningeal arteries enlarged, and then it is refluxing into the cortical vein. So this reflux into the cortical veins is dangerous because then these veins become ectatic and then they rupture and they cause hemorrhage. So this is the Cognard classification which is being followed. For classification of DAVFs, you can have type 1 where there is a DAVF but it is an antegrade flow, that is it's a physiological flow. So this is supposed to go down. Here also the fistula's blood is also going down. It's Cognard 1. It is a benign kind of DAVF. It can be simply followed up if the patient is not complaining of any symptom. Now a type 2A is when the DAVF has a retrograde flow. Okay, here there is no antegrade, this is a retrograde flow that it is refluxing into the large venous sinus. 2B is there is an antegrade flow along with a cortical venous reflux. 2A plus B is there is a retrograde flow with a venous reflux. So whenever there is a venous reflux, it becomes dangerous because these cortical veins are not meant to accept the retrograde flow of blood. As they start receiving this kind of blood, they will become ectatic. So this is a different type where the fistula is directly draining into the cortical vein, and when they become ectatic, it becomes type 4. So type 3 and type 4 are very dangerous. They are highly prone to bleed, and sometimes you can have perimedullary venous drainage. That is, the fistula is at the level of the skull base, but it drains in the spinal cord. This kind of patient can lead to spinal congestive myelopathy. Just the last part of my talk, we're going ahead to spinal cord. Here you can have spinal cord infarcts, shunting spinal vascular malformations, and non-shunting spinal malformations. So spinal cord infarct is already covered. I'll not be going there. The non-shunting type is cavernoma only. You don't see much of DVAs in cord. It is difficult to appreciate. Neither do we describe this one, capillary malformations. So this classification we need to remember for spinal vascular malformation. A type 1 is a dural AV fistulas. A type 2 vascular malformation is intramedullary glomus tumor. A type 3 is intramedullary juvenile AVM. We'll talk about it. Type 4 is a perimedullary. This is akin to an AVF that's on the surface of the cord. And type 5 is an extradural AVF. So this is what we're going to encounter the most, the type 1 DAVF, where the fistula is at the nerve root sleeve. It is between the radicular artery and the intradural venous system, and it will lead to venous hypertension. Now, the classical morphology we know, these are generally elderly male patient, okay, presenting with gradually progressive paraparesis, weakness of the lower limbs, and most of the DAVFs, they will have dorsal in location. 85% of them will be located between T6 to L2 vertebra. Look at the classical imaging feature. Again, we have discussed an edema which is central in location, peripheral T2 hypointensity. Now, why the central part is involved? Because this is how the central venous hypertension starts, from center to periphery and from down to up. So wherever is the fistula, you will have the edema starting from the conus. Conus is invariably involved in case of spinal dural AV fistulas. To be able to demonstrate this small flow voids, you need to acquire a cis 3D sequence, a thin sequence in the SAG plane, and it can always show contrast enhancement. This is because of blood spinal cord barrier breakdown. Because of chronic venous hypertension, there will be this kind of enhancement. Now we have all talked about missing peace sign in detail, so I'll not go ahead with it. But this is also one of the signs which is described, though it is very rarely seen in our practice. If you have MR tricks, that is a possibility to acquire a time-resolved dynamics angiogram, do acquire it, because it always helps us to localize the fistula. Then the spinal DSA becomes a less cumbersome process we can selectively go and cannulate few of the radicals and make a diagnosis. So spinal angiograms preferably to be done under GA, and where different kind of catheters are required, like Cobra 2 or SIM2, and then we do it from dorsal till the L4 vertebra, then the internal iliacs are hooked. And if you are not able to make a diagnosis, you have to hook both the vertebral arteries, both the ECS and both the ICS to make a diagnosis of dural AFib. So this is a classical example here. You can see this is one of the radicular artery which is feeding the spinal dural AV fistula. Like brain AVMs, you have spinal AVMs also, and here they are classified into type 2. So you will have a nidus in the cord with multiple flow voids. Here you can have flow void both in the anterior and the posterior surface. You can have cord edema. You can have evidence of bleed within the cord as well. And this is a spinal angiogram where we can demonstrate this is a PSA actually feeling the nidus with intranidal aneurysm. So even this spinal cord AVM had an intranidal aneurysm, and particularly this one had ruptured. So this is a classical example of a spinal AVM. The type 3 is juvenile type, which means it's a metameric involvement, that is involved on the cord, the vertebra, and the surrounding soft tissue. So this is also called a Parkes-Weber syndrome. This is a juvenile type where the entire metamere will be involved. A type 4 is a perimedullary AVFs. These on the surface, you can have different types: type 1A, type 2B, type 4A, type 4B, and type 4C. Just to give you an example, this is a classical example here. You can see a large venous varix, and which is being fed by multiple radicular arteries. And type 5 is an extradural AVFs. So to conclude, the cerebral and spinal vascular malformations are broadly classified by presence and absence of shunts, so that we have discussed, and you have to optimize your sequences based on what you are looking for. Like for brain AVFs, I've already discussed. For atypical bleeds, I've already discussed. Okay, thank you. If any question, we can discuss, or we can straightforward move to the classical. Okay, for this session, I will not be speaking. Somebody else should speak. I mean, it should be the participants. They should start picking up cases and describing. Lights? Shall we start? I think we can switch off a few of them. Off. Lights. Grade 2 glioma in 2016. He received radiotherapy, 28 cycles. Now presented with complaints of headache, left-sided hemiparesis, and right-sided facial deviation. So this case we did starting of this year. So it is 8 years after surgery. Okay. What's happening? Can somebody describe? Okay, so I'll just show you. So this is the post-operative defect that we are seeing here in the right frontal lobe, and this is the this is the flare image where we see subtle white matter hyperintensity in the contralateral cingulate, but otherwise you don't see anything over here except the post-operative changes. Because of the patient's symptom, the patient underwent contrast study, right? So this is the post-contrast scan. This is the post-contrast T1 MP rate sequence, and this is a ASL image. So what do we see here? We see some amount of gyriform enhancement, right? Which is non-territorial, kind of involving the right frontal lobe extending up to the motor cortex. So this is the central sulcus. The entire frontal lobe is getting involved, right? And you have this gross cortical edema as well. And this is the ASL image, which is showing raised perfusion. Now your differentials and diagnosis. You can say whatever. So a patient of treated glioma declared cure for 8 years comes back to your ER with this headache and weakness, and this is your findings. Recurrence? Tumor recurrence. That is the first. That was like when I was sitting there. This was my. This is a VVIP person. VVIP person. All of them are there. Like, recurrence है क्या? Radiation necrosis का age group क्या होता है? So usual radiation necrosis starts at 6 months, after 6 months, and 80% of the cases are within 2 years, 95% of cases within 3 years. So it can occur this late also, but this is rare. We'll put it down the differential diagnosis. Anything else? Stroke, but this is non-territorial. 1, 2, that there is raised perfusion. Right? Both of them are there. Yes, sir. This is a SMART syndrome. So this is a SMART diagnosis, right? So why it is SMART? Because it allays the apprehension of everybody, the patient, the physician, and everyone. So this was SMART syndrome. What is SMART? Stroke-like migraine headaches after radiation therapy. This is basically because of blood-brain barrier breakage, right? And what to do with such cases? So the same patient, was given corticosteroid, and the patient comes back after 6 weeks, nothing is there, right? The enhancement has gone. You don't see any raised perfusion as well. So this is completely stabilized. So if you know the diagnosis, the patient can be counseled accordingly. All right. Second case, I want some active participants, just say something. So this 4-year-old female, she complains of isosexual precox puberty. There is vaginal spotting for 2 months. It's a 4-year-old kid. There is no growth of pubic hair. There is breast development tenors too at 4 years of age. Normal IQ, delayed walking. Now the serum estradiol is 90.75. Normal range is below 15, right? Testosterone is 90.76. Normal range is below 15. In girls, it is below 1. And TSH is 150 IU per ml. Okay. The patient was sent to us for an MR, and this was the MR finding. Now, the surgeon is saying, why this young kid is having this? Should I operate or should I not? What should I do? What is the finding here? The pituitary gland is enlarged, right? Anything atypical in this pituitary gland enlargement? It's quite significantly enlarged actually, if you see. And it is not reached up to the optic chiasm, but the posterior bright spot is maintained. There is no loss of posterior bright spot, and you have this homogeneous enhancement. Pituitary adenoma. All right. So this was the query that discussion was going on, whether to take the patient or not. So what we did, we reviewed whatever has been done for the patient. So the patient has undergone a thyroid ultrasound, right? It shows thyroiditis like picture. Okay, there is increased vascularity in the thyroid. Now this is the hand X-ray, right? So at 4 years of age, we are expected to have 4 metacarpal bones. Here there is 2.5 actually. 3 is seen, so 2.5. So there is definitely a delayed bone age. Okay, बहुत सारे findings आ रहे हैं. Delayed bone age. You have thyroiditis. You have a pituitary. What are these? This is a pelvic ultrasound was done. What are you seeing here? For a 4-year-old girl, the ovaries are quite large, right? This is the right ovary. Multiple follicles are seen. This is the left ovary. A large cyst is seen in the left ovary. Look at the uterus. This is looking like an 18-year-old uterus, right? The endometrium is full developed. And at 4 years, uterus will be less than 6 centimeter. This is looking like an adult uterus. This is the MRI of the abdomen. So I called up my pediatric radiologist as well, and we discussed this case. And she told me, sir, ye kuch bhi nahi hai. Don't worry about this. And we did something, and this is the follow-up after 3 months. We did something and the patient came back after 3 months with absolute normal. Now tell me. McCune-Albright में क्या होता है? So McCune-Albright is Precocious puberty is fine, but what is happening to there is a pituitary adenoma only, right? That will not go away, right? Thyroid then? Yes. So this is secondary to diffuse hypothyroidism. This is secondary to diffuse hypothyroidism. The diagnosis here is von Wick, whatever, Grumbach syndrome. Now don't go by the name, just go by it. What has actually happened here? The patient had a juvenile hypothyroidism, right? In this particular case, it is autoimmune thyroiditis because of the kind of perfusion we got, leading to pituitary hyperplasia. So the problem there was pituitary hyperplasia. Whenever you see very raised TSS levels with enlarged pituitary gland, with normal pituitary bright spot, don't operate. Just replaced thyroid. So the patient was replaced thyroid. And all the other features, if you see, delayed bone age is a classical finding of hypothyroidism. Okay, so this everything, and here because of the excess TSH, you had excess FSH. Okay, and that led to increased production of estrogen, and that led to the enlarged ovaries. It is rare in male, but it can happen in males also, and then in that case they will have microorchidism. The testes will be enlarged. So this is the treatment was only thyroxine supplementation. Only that thing was done. After that, we did a trial. We told our endocrine counterpart to send us all patients whose TSH is more than 100. We did 10 patient scan, 5 patients had thyroid hyperplasia. So not uncommon. We don't image them because the patients are not symptomatic, and because it doesn't enlarge enough to go and compress the optic chiasm, so they don't become symptomatic. All right. Okay. Again, a 4-year-old girl who was brought for evaluation of non-resolving hydrocephalus. Okay, she has been diagnosed with tubercular meningitis, and she is refractory to tubercular therapy. Came to us for opinion. If you know, you know. You don't know, you don't know. It's a simple case. What is here happening? It's a spotter. Now, this is not a case for discussion. It's a spotter. If you're not able to spot, we'll go ahead. This is DLGNT. So this is, now I'll tell you what is happening here. Now, this patient was treated for ATT for around 1.5 to 2 years and was declared refractory. She had hydrocephalus. That's why you can see a drain being put here. If you see this thin sections, you have multiple subpial cysts. There are multiple cysts in the cerebral folial spaces along the optic chiasm, along the extensive pile surface. Subpial cysts are there. These are the T1 images which are showing small areas of, T1 hypointensities. These are the flare images showing peripheral hyperintensities. In the contrast image, there is leptomeningeal enhancement. So the disease is in the leptomeninges, and in the leptomeninges they are forming multiple cysts which are showing peripheral enhancement. The cord is also involved. You have this kind of cysts which are going down along the cord, and you can have intraparenchymal cord involvement as well. So there are multiple theories. They say in DLGNT, the cord is the primary site, and there are multiple disputed things on that. And this is the post-contrast scan. If you see that there is enhancement of the surface of the cord, it's entirely a leptomeningeal disease. So diagnosis is diffuse leptomeningeal glioneuronal tumor. It is one of the mimics of CNS tuberculosis, where you have this kind of subpial cysts. It is a new entrant in the CNS classification in 2016, and not very uncommon because I have seen 4 cases so far. So it cannot be that uncommon condition. Okay, now this case 4. So this case came last month, I think. This 32-year-old male, it was put to us for this weekly meeting. This image was brought. This patient has come in emergency. Please give your opinion. The patient came and got intubated immediately. So this presented with headache, left-sided hemiparesis, and loss of consciousness. Images are very bad, but this is what I got. So I'm giving it to you. Can you make a diagnosis? And it was a fight between the neurosurgeon and the neurologist. Whose patient is it anyways? Who will keep the patient? Will it go for the neurosurgery arm or will it go for the neurology arm? So what do we see here? There is basal ganglionic involvement, and it is asymmetric. The right side is getting involved. The thalamus, bilateral thalamus is actually involved, but with an asymmetry right side more than the left side, right? This is a T1 weighted image. The edema is very well appreciated here. This is diffusion. There is diffusion brightness, not frankly restricting. We don't have the ADC. These are the GRE images, gradient image. Like we have SWI, like some of the basic scanners will have GRE images, which will pick up blood. Blood will appear black. So you can see the deep systems here. Listen, slightly black here. And this is the post-contrast T1 amperage. I picked up something here which may help me make the diagnosis. Deep CSVT. So what are the differentials for this kind of involvement where we have bilateral thalamic involvement? Like if we try to reach from here, what are the other conditions which can lead to bilateral thalamic involvement? Japanese encephalitis, right? But then asymmetry and this kind of edematous with this venous thing is not being explained. Other differential? Bithalamic gliomas, right? Artery of purturin infarct, then would have shown frank diffusion restriction. And then, okay, malaria will also come in because of this, again, same pathology. So again, then the patient underwent a CT scan. You can see this is a plain scan. Some hemorrhagic areas have also started appearing. And if you can see, this is the thrombus here, sitting in the vein of Galen and the straight sinus. Oh, okay. I thought I'm showing my cursor. Okay, sorry. Yeah. You can see this thrombus over here. Even in the previous image, if you see here, you can see the thrombus here in the straight sinus. So they have given this particular image, and if you see this is the basal vein of Rosenthal, the vein of Galen. They are appearing dark. This is because thrombus sitting in the deep venous sinus. Okay, so deep CVT. We'll see more cases. So this case is like a revision, 41-year-old, PLHA since 15 years, with past history of pulmonary TB, now presenting with altered sensorium and GTCA. This is last week's case only. Now, can somebody make a diagnosis here? So, if you see, this light could have been off actually. You see that there are multiple dots here. Can you see the dots? Yeah? Yeah. So you can see this multiple dots with white matter involving the subcortical white matter. Then there is asymmetric basal ganglia involvement here. So what is this? So you have galaxy and the shrimp together. So it's a shrimp in the galaxy, right? So we have PML. Okay, so we get in the same case, you got a shrimp sign and you get and actually if you see these two images, they look kind of Milky Way sign, isn't it? So this is a case of PML. Okay, again, you have seen this case also. This 29-year-old male presented with complaints of insidious onset of gradually progressive tightness and weakness of bilateral limbs and difficulty in micturition for 3 years. What is happening? Now, what do we see in these images? I can tell you the sets of images. These are two T2 images, DWI ADC. We'll show more images. So, but one thing is sure, whatever you're seeing is quite symmetric. So whenever you see symmetric images, we are talking about metabolic. So that we are sure we can come to a thing that we are dealing with metabolic here. Okay, this is. So you have specific tracts involvement, dentate involvement. Look at this inferior cerebral peduncle getting involved. The lateral part of the spine getting involved. So specific tracts getting involved here. And what is this? LBSL, right? So this is, we have seen this case of LBSL. When you have this kind of dorsal and lateral column involvement, major tracts getting involved, demonstration of lactate peak on spectroscopy, and this symmetrical white matter involvement, this is the classical example of LBSL. So you should ask me which TE I have acquired this. Okay. So it will depend on what TE you are looking at. At 144 inwards, it will be an upright peak in 35. This is low TE scan. Okay, history. 22-year-old male, headache, vomiting for 4 to 6 weeks, weakness in all 4 limbs, loss of bowel and bladder control for 10 days. Okay, so this is what happened in the night. I can tell you the first 3 images are plain scan. their plain scan. What do we see here in the plain CT scan? So this was done in emergency. Hanji? Yes? Lead poisoning. Why so rare diagnosis? Okay. So one thing is very obvious. Now. This is, what is the age? 22-year-old. We don't expect the ventricles to be this big. Ventricles are enlarged for sure, right? Okay. Subarachnoid hemorrhage. Okay. Spinal avium. Pile avium. Okay. So one thing was, it was actually told by my JR on call that this is a SAH, and he went ahead and did a CT angiogram. So I have put the CT angiogram also, which was negative. Okay, there are no aneurysm in the CT angiogram. And then morning when I came, he told me, sir, एक SAH हुआ है, देख लो. Please see the scan. So this is not SAH. Blood is not dependent, right? Everything is getting coated over here. Can you see this? SAH. So we should think of a chronic meningitic process. All right. So I thought this is not SAH, this is some chronic meningitis. Let's just get the patient for MR. So then MR is done. Okay. So this is the T2 weighted image. You can see this lining along the surface. You can see the lining along the surface. There's T2 hypointense lining along the surface. This is the post-contrast scan showing leptomeningeal enhancement. Right? This is the post-contrast T1. You see this thick enhancement. Whenever you see this kind of thick enhancement, it is not acute. We're dealing with a chronic meningitic process. And always think of a malignant pathology. But this is a 24-year-old. Okay? Look at this kind of thick enhancement. Importantly, these two images are plain images. Yeah.
Is there any plain T1?
First two images are plain T1 only. So then you go and look at the patient, and the diagnosis is very easy. So just to one more point, when you have this kind of deposits on the surface of the cord, you can get this kind of flow voids also, because the veins also get compressed by these exudates, and they can lead to a malformative kind of an appearance. So there is a similar image in this one, which is published in Radiology. Similar kind of image. We wanted to do a spinal angiogram, but we lost the patient. The patient was very bad, and we could not take the patient for a spinal angiogram. So this is neurocutaneous melanomatosis. So it's very important that here it's a pseudo-SH appearance actually. This is a pseudo-SH appearance. This is one of the cause of pseudo-SH appearance when you have melanin-like deposits in the brain which will appear hyperdense on plain CT scan. So this is a different patient again. All these images are plain T1 image. You have this T1 hyperintense deposit in the subdural and the subarachnoid space. You have this hyperintensity in bilateral amygdala. Okay, this is also a case of this particular patient was also on ATT for 2 years. This is what happened because we don't see the basic T1 image. We tend to miss this kind of cases. So this was a diffuse meningeal melanomatosis. Okay. So next case, this 28-year-old right-handed male patient presented with history of 2 episodes of generalized seizure in October 2022. So this is back then. Additionally, he reported experiencing. Okay, there is bilateral bifrontal headache. So bifrontal headache, seizures in a 28-year-old male, and this is what we have. So left frontal. Okay. What is the signal characteristics? It is hypointense on T2. Surface base, cortical base, T2 hypointense lesions over here. And look at this area. T1, DWI, ADC, mildly restricting. Not much of blooming on the SWI image. This is the post-contrast image. Ill-defined enhancement, very bright, something that we saw in the morning like lymphoma. Vasculitis. Okay. Whenever you see something T2 dark showing this kind of enhancement, think of gangliomatous pathology, number one. Okay, so this actually was diagnosed as meningioma outside, and the images were reviewed to us just before the surgery. So the surgeon asked, does it look like a TB? Should I, sir, I can't say that it's looking like TB. This does look like ganglion pathology. If you do a biopsy, we'll have a diagnosis. So, and this is the ASL. If it was a tumor, a meningioma, it should have shown increased perfusion. It's not there. It is showing rather decreased perfusion. So we thought it's a gangliomatous pathology. This is what we told. Let's go ahead with the. So these differentials were kept by me. I'm not putting the original diagnosis. I didn't diagnose it in the first place. These were my differential that I put. Patient underwent biopsy. All right. Patient went home, and on that evening, when the patient came back to the emergency, we got the final report from the path department. But the same evening, the patient dipped, and this is when he came to the emergency. This is his repeat MRI. You can see that this is the resection cavity. You have increased perilesional edema, lot of vasogenic edema is there, mass effect is there. There are new lesions. Like the posterior fossa was spared, you have new lesions in the posterior fossa, bilateral cerebellar involvement, pontine involvement. There's a hemorrhage in the thalamus as well. You can see this. So multiple lesions now, bilateral hemisphere. Now this lesion in the left cingulate area, it is showing hemorrhage. So now the lesions are becoming more hemorrhagic. And this is the post-contrast scan. All of them are showing vague enhancement. This is the cord. You can see enhancing lesion in the cord as well. This was a case of granulomatous amoebic encephalitis. So it's a granulomatous pathology, and the same morning the pathologist came and saw, I am seeing Balamuthia. So this was Balamuthia proven case. When they did everything actually, in fact, they got medicines from I think Chandigarh PGI and everything they did, but they could not save the patient. It's a bad diagnosis to have. Just to highlight this kind of appearance, it's a granulomatous pathology. You should keep a granular pathology and then evaluate further. Here the bad thing was somehow steroid was prescribed, which should not have been prescribed in this particular case. Okay, some easy cases. This 1.5-year-old male presented with complaints of headache, nausea, vomiting, seizures, hearing loss, and decreased visual acuity. Power is reduced in proximal limbs. Spotter this is. So you have symmetrical involvement, right? So dealing about metabolics, correct. So bilateral, putamen, okay, peduncles, lays, classical lays. Okay, so this is and you have this olives. Whenever you see symmetrical involvement of olives along with periaqueductal, keep leaks as a differential diagnosis. I'm not going to it. Let us move to some other case. This 6-year-old central DI under evaluation. What do we see here? So this is a plain T1 image. We don't see the bright spot, right? Whenever they talk about DI, we need to go back and see the pituitary bright spot. We are not seeing the pituitary bright spot. See the corpus callosum, it is looking little thinned out and subtle hyperintensities involving the corpus callosum. This is the post-contrast T1 image. What is this? For a young kid, this much of enlarged choroid plexus is not expected. So enlarged bilateral choroid plexus. What is this? This T2 hypointensity over here. This is involvement of the tentoriums. A very T2 hypointense tentorium, which is showing heterogeneous mild to moderate enhancement. This is symmetrical kind of involvement of peridentate white matter as well as the pontine tegmentum. So in a 6-year-old, if you can combine everything, it is classical LCH. The classical LCH, if you see this kind of cerebellar involvement, enlarged choroid plexus is also a feature of LCH. And this kind of tentorial involvement is known in patients with LCH. So that's what we told, loss of pituitary bright spot, thickening of pituitary stalk. Okay, so all these features are there. Okay, This 50-year-old male, this is also a bad patient who came, was referred from outside. He presented with quadriparesis followed by difficulty in speech, urinary incontinence and constipation. Patient also complains of cervical neck pain. There was, however, no evidence of sensory disturbance. On examination, patient had absent gag reflex, exaggerated jaw reflex, and no other neuropathies at admission. So by the time we took the patient for MR, so the patient was already intubated. Now just see the scan. What is the abnormality here? You see abnormal signal involving the medulla, right? And the cervicomedullary junction, because this is the upper part of cervical cord. So what do we see here, which is not normal apart from the signal abnormality? Okay, you can see this, there are multiple, right, flow voids. Anything here? So you have this T2 stage, this is a TOF MRA, and this is the thick sections of the TOF MRA. This is not TOF, this is I think post-contrast MR angiogram. So you can see this medulla is involved. You see a large flow void over here. Okay, so you see a large flow void over here, and this irregularity that you see, T2 high point irregularity, these are actually flow voids which are on the surface of the cervical cord. In this angiogram, if you see that there is a tuft of vessel that you can see here on the dorsal part of the cervicomedullary junction. What is it? What you will give a diagnosis here? This is what we have generally. This is what we do max. AVM. Here it is it in the parenchyma? Anything in the parenchyma? No, nothing is in the parenchyma. The parenchyma is edematous secondary to these flow voids. They're on the surface. Dural AV fistulas, okay? So we did a DSA, and in this particular case, this is a selective injection of the ascending pharyngeal artery, okay? And this is the ECA injection, and it is feeding this is the venous pouch which is feeded by the ascending pharyngeal artery. So intracranial venous circulation filling by an by an extracranial artery. This is a dural AV fistula only, and in this particular case, it is located around the condyle. So these are called condylar DAVFs. We did took the patient immediately for embolization, but the patient actually crashed just before we could start the procedure. Okay, let's see this case. 7-year-old male presented with congenital ichthysis and spastic diaplegia. If we can make a diagnosis from here only, it's better from the skin. It's a scaly skin, right? It's a diffuse scaly skin. If you see the brain, you can see the corpus callosum is getting involved. You see this hyperintensity in the corpus callosum and bilateral symmetrical centrum semiovale involvement. And if we do a spectroscopy, you find a lipid peak at this is at 144 TE. So you have this is elevated lipid peak at 1.3 ppm. So dry skin, symmetrical centrum semiovale lesion with a lipid peak on spectroscopy. This is Sjogren-Larsen syndrome. It is basically a disorder of fatty acid metabolism. Okay, here the catch point is the skin lesions only. Generally, we get it referred from our pediatric neurologist writing, please exclude this condition. And he wants us to do a MR spectroscopy for the patient. And when we are able to demonstrate this kind of white matter lesions in bilateral centrum semiovale, we are very sure. This is one more patient again. This is, look at the skin. I hope it is represented. Look at the skin, scaly skin, right? Like a fish scale. And again, here you have this symmetrical lesions in bilateral centrum semiovale. And again, we did a spectroscopy and we found a lipid peak. A consistent story. So this is classical of Sjogren-Larsen syndrome. All right. So this 22-year-old male presented with chronic headache and vertigo. This is a spotter actually. If you know, you know. So I'll just try to describe it. T2 weighted image, SAG image. You have this T2 hypointensity lesion which is extending from the sella in prepontine cistern, premedullary cistern, and entering the upper cervical canal, right? Which is appearing bright on T1. So what are the things which can be bright on T1. Calcium, free calcium. Okay, or blood can be bright. Calcium, then melanin, we have seen melanin example. Then proteinaceous material. So protein we have not shown. This might be protein. What is there? So DW I have not put here. so okay, and yeah, epidermoids can also turn into bright. So the bright epidermoids are differential, but this location is quite characteristic for neuroenteric cyst. And this pre-pontine location trapping the basilar artery, it is quite characteristic for neuroenteric cyst. Okay, and the diagnosis here is T1 hyperintensity, the location itself. Okay, this particular case of viral meningoencephalitis presented with refractory status epilepticus. Okay, last week's case. So what do we see here? That there is left hippocampal hyperintensity on FLAIR image. What is these two structures here? Claustrum is involved, right? So there is this claustrum is showing. Is it showing restriction? It is showing restriction, right? So there is hyperintensity in bilateral, this one, and nothing much there. So what is the diagnosis here? Autoimmune. So this is basically a case of Fires Norse. It's the claustrum sign described in febrile infection-related epilepsy syndrome. The Fires Norse, these are all nowadays put under the same basket of ITES, infection triggered encephalopathy syndrome. So all this, your MERS, Fires, Norse, alert. Okay, so these are all under the same basket of infection triggered hypercytokinemia, and then they will lead to this kind of brain inflammation, ANE. So these are all ITES spectrum disorders. Okay, simple case, spotter again. So this 52-year-old present with altered sensorium with seizure and behavioral changes. HSV, no Sochna V nahi hai na, this is HSV. So we also told the same. Patient was started treatment. He improved. He went home, came back again after 1 month. Okay, and this is his scan again. What has happened? And this time he has some movement disorder also. Yes, so this is post herpes induced NMDA. So this patient improved, went back home, came again, and you can see that there is this time these lesions have healed. They've turned into gliosis, but the ASL shows this kind of raised perfusion changes. So this was post HSV anti-NMDA encephalitis. All right. This 10-month-old male presented with posturing of all 4 limbs for 25 days, complaining of breathing difficulty, altered sensorium for 2 days. What is normal or what is abnormal here? He is a 10-month-old kid. Molar tooth sign. You see what you want to see. Yes, it's okay. Anything else which is grossly abnormal? Bolo, tell. Basal ganglia hyperintensity. Dentate also hyperintense. Actually here everything is hyperintense. For a 10-month-old kid, if you see, look at this cerebellum, everything is bright. Look at the white matter, okay? Look at the globus pallidus, everything is very bright on T1. We can go back to the list. What are the things that are bright on T1? We can revise again. What is happening here? At 9 months, we have early mineralization of bilateral globus pallidus, and there is early mineralization of the dentate nucleus. All right. T2 weighted image. So myelination has happened, but it is kind of very, like everything is looking very dark here, you can see. Okay, very dark signal in the globus pallidus is very hypointense. Look at the cerebellar white matter. So it's appearing too much dark on the T2 weighted images. What can be bright on T1? Again, let's go back. Revise. We have seen blood. We have seen melanin. We have seen protein, calcium. Yes, ma'am. Yes, ma'am. Other things which can be bright on T1. Suppose I give a clinical scenario. A patient who is alcoholic, and we see a bright signal on globus pallidus. It is manganese. Because of not able to metabolize. Manganese. So if there is a manganese co-transporter defect in pediatric population, So magnesium co-transporter defect can also appear like that. This was, we suspected it is because of hypermagnesemia, and it came out as hypermagnesemia. So there are different types. These are all genetic proven cases, but we wrote specifically, we checked his magnesium is very, very high, and then genetically also it is proven as hypermagnesemia with dystonia type 2. I'm not good at genetics and neither remembering names, but pattern recognition always helps. What is this? This is panda, right? This is a classical example of giant panda. So we can see that this is the face, right? The eyes, the ears of the panda, and everything. The striatum is classically involved. Okay, so you can have the involvement of striatum. Striatum means involvement of the caudate nucleus as well as the putamen. That is fine. Apart from that, if the patient is untreated, you can have cortical involvement also. So cortical involvement is also known with Wilson's, and if it is getting involved, it's mostly the frontal lobes. You can see here, and they will become cystic like this. This is a classical example of Wilson's, and this is also one patient that we saw last month. Let's see here what is happening. So this is a neglected case, untreated case. You have bilateral MCP involvement. Apart from the classical midbrain involvement, the panda, the thalamus is also getting involved. There is this vacuolization of the external capsule, and you have frontal involvement with peripheral diffusion restriction also. Okay, so just remember this kind of white matter involvement, symmetrical white matter involvement of frontal followed by temporal lobe is also known in case of Wilson's disease. This is an easy case, 8 months. I'm just finishing. 2 more cases. 8-month-old, hypotonia, cortical blindness, microcephaly. ये तो spotter है. Diffuse involvement, right? Diffuse involvement with prominent VR spaces and a high and then a peak. Classical case of Canavan's disease. This one, last 59-year-old male, gradual painless vision loss with growth in right eye. T2, this is a plain T1 image. This is a contrast T1 image. Yes, choroid melanoma with extension along the optic nerve with intracranial extension, right? So this tumor has extended across the optic nerve and has shown intracranial extension. Done.
Not many are left for this last session. I thank, first of all, Dr. Anantram to make this session happen. It was an 11th moment decision, and right from arranging from all the participants' topics, everything, you have been a major contributor for this. So a round of applause for Dr. Anantram. Thank you for all the speakers as well coming up, whatever remaining of the participants. So it's difficult to sacrifice one alone Sunday and stay throughout the session. So thanks a lot for all the participants as well. And vote of thanks for all the pharma people, ICON, their team, our organizing team, branding team, Srinivas, all our technical staff. So I think without any further ado, we'll call it a day. Thank you all. And 6th monthly, we will be meeting for a similar practical update. Hopefully a little more enthusiastic participation from you, your colleagues, future other residents. So 6 months from now, we are planning to have a session on movement disorders. So we'll most likely be troubling you people again. So thank you. Thanks a lot.